Good afternoon, everyone. On behalf of the Indian Academy of Pediatrics, the Twin Cities branch, I welcome you all to today's IAPTCB CME. Today's topic is on pediatric emergencies and critical care. And this is the first physical CME we're having. COVID has brought unexpected and unforeseen circumstances, because of which we had to connect virtually. And post the vaccination, it has given us the opportunity to connect back with all due COVID appropriate behaviors. Henceforth, IAPTCB aims to have at least 1 or 2 physical sessions so that we can interact and get the old days back. And we give a warm welcome to all the delegates, both online and also offline. And we intend to continue this practice of ensuring that these sessions are recorded, and we'll be able to leverage technology to address these sessions later on as well. I have warm wishes from our president, Dr. E. Arjun, who was not able to make it today, and also on behalf of the entire executive board of IAPTCB 2021 team. And we're all excited to take this forward, and in this year make a year which is full of academics and welfare of the members as top priority for IAPTCB. I extend warm welcome to all the delegates here, and also to our Central Zone Vice President of Indian Academy of Pediatrics, Dr. Ravi Kumar sir. May I now request Dr. Sunkoj Bhaskar, President-elect, to say a few words. Dr. Bhaskar, please.
Good afternoon all. I'm Dr. Bhaskar, because many of you may not be knowing me. Today I'm here as a president-elect, not the president of IAPTCB. As our constitution demands, in his absence, president-elect has to preside over this CME program. I'm really excited to have this physical meet, first of its kind after installation ceremony, which was held in February 2021. I think it's January, I'm sorry, January 2021. And just a reminder that we had TCB annual Pedicon, first of its kind in the history, to have a hybrid conference, subsequently which was followed by national conference and other conferences. So thanks to EB 2020. Since last 25 years, this Rainbow Children Hospital has been consistently supporting the academic activities and other activities of IAP Twin Cities branch. For this, on behalf of EB 2021, my special thanks to Team Rainbow for extending wonderful, great support to us since last 25 years. And secondly, whenever there is a scientific program from Rainbow, it's something special, unlike routine CMEs. Even if you take today's CME, we had seen many CMEs and pediatric emergencies, many workshops on pediatric emergencies. But if you go through that carefully, algorithm-based discussions on pediatric emergencies, I think, to the best of my knowledge, it's one of its kind, or maybe one of the few times we are seeing this algorithm-based pediatric emergencies. So that is the specialty of Rainbow. And lastly, I'm happy to see many participants, because this is the inspiration and enthusiasm and support to the faculty. I know how difficult for the faculty members to prepare the CME and to present it. So it's a great support to them. And similarly, if you are not there, however best the faculty is, it's zero. So similarly, if you are there and CME faculty is not there, it's zero. So it's a symbiosis. Both of us get benefited. Learners like me will get benefited. I think faculty members should tell us that even they do get benefited, probably they do learn by going through this. So with these few remarks, I request you all to participate in our upcoming Vaccindicon on 3rd and 4th April. 3rd and 4th April. First day we have a conference on infectious diseases from PATS, that is IAP Telangana State. And second day is on vaccinology from IAPTCB, to be specific. But in general, it is from IAP Twin Cities and Telangana State. That's going to be a wonderful program. We have workshops, and I request all of you to attend. Very luminaries from entire country had accepted to participate in this program. And last but not least, this program, though we didn't announce it, but it's being sent on the YouTube the moment the CME program starts. So thank you one and all. Long live IAP. Jai Hind.
Thank you, Dr. Bhaskar. Let us now start the CME. I now request Dr. Ravi Kumar sir, the Central Zone Vice President of Indian Academy of Pediatrics. Sir, please come on stage. Also invite Dr. Dinesh Chirla, the Managing Director, Rainbow Children's Hospital. I now hand it over to the chairpersons to take it forward. Dinesh sir, a small welcome from you, and then you can take it forward from there.
Good afternoon, everyone, and welcome to this CME on pediatric emergencies. It's nice to see the hall sort of full with all the students and the senior pediatricians. The COVID has been challenging. We all have been sort of just stopping flooded with webinars, but it's nice to have a 1:1 sort of interaction. You have galaxy of speakers who have actually worked with emergencies, so who can give a lot of practical tips to you about how to handle these emergencies. So not only the algorithms, you have quite senior sort of pediatric intensivist, Dr. Farhan Sheikh, Dr. Parag, Dr. Kapil, Dr. Anupama, and Dr. Nitin and Dr. Chetan. So all a very senior sort of pediatric intensivist and emergency specialist who would be sort of enlightening you on all different pediatric emergencies. Have a great learning. Thank you.
Thank you, Dr. Dinesh. I now invite Dr. Ravi Kumar sir for his inaugural remarks, and then you can take the technical session forward.
Good evening, everyone. I know in the total pediatrics, the most challenging subject is emergency medicine. These routine cough, cold, upper respiratory tract infection, anybody can handle. But even today, I feel like working in a emergency service room. Even today also I'm posted in ESR. So that is the time where your real student, the student will get real thrill. The first time he is seeing the case without anybody touching or anybody giving their opinion, he has to give an opinion and he has to handle the case. So the most interesting item for, I'm sure, for any academician or any student is the emergency medicine, emergency pediatrics or whatever it may be. So emergency medicine. I'm sure you are all going to get excellent benefit. I could be able to see Farhan Sheikh, Parek, all intensivists. Sometime back, our former pediatricians from the Nilafar Hospital who have now done the intensive care and working here. Of course, Dinesh is an all-rounder like a Kapil Dev. So I wish all of you and all the gathered members will get benefit out of this, especially the third topic, which is my favorite, that's asthma. And day to day, everybody will be doing mistakes in spite of knowing everything from the third year onwards. So that is one thing. Outside, most of the times we'll be doing the mistakes. That I'm sure today it will be cleared by the faculty. Thank you very much for inviting me and giving this opportunity. Thank you.
The first talk now today is by Dr. Anupama. She'll give an algorithm approach to, I think a lot of time as pediatricians, when we see a child with burns, we really don't know how to approach it. And I think as a trainee, a lot of time we just leave it to the surgeons. And we all of us know that it's a lot to do with prevention of infection or management of infections appropriately, fluid management, pain relief. So many things are there in it, which as a pediatrician and an intensivist, we should know it appropriately. And similarly, when approaching to poisoning, what are we doing with it? How do we structurally sort of approach any child whom we suspect to have poisoning? So Dr. Anupama is one of the senior pediatric intensivists with the Rainbow Children's Hospital. May I please ask her to come on and take the session? Thank you.
Before Dr. Anupama starts, acknowledge the presence of Dr. Suren Nath, the President of Indian Academy of Pediatrics, Telangana State Branch. Over to you, Dr. Anupama. Share it from here. Share close. Close this.
Shall I close this?
Yeah, close that back. No, not this, not this. Just click on the share screen. Yeah, just you close so that it doesn't. Yeah. Go back to the meeting. Yeah, just అదే. Yeah. I exit minimize ఉంది కదా. Agree. Yeah. That's అది click చేయాలి. అది click చేసాక share. No, you have to click on the presentation. Stop share.
When we used to MacBook, no? So
Yeah. Share screen. Yeah, click on it. Double click. Yeah. Double click change. Yeah, now share. Yeah. Go to full screen or slideshow. You're on.
Good afternoon, all. I would like to thank Rainbow Children's Hospital and IAPTCB for giving me this opportunity. So basically, I will be talking about burns and poisoning, both of which are preventable health problems in children. More than 90% of toxic exposure occurs at home, and ingestion is one of the common route of poisoning. Accidental poisoning we know is the 12th leading cause of admission. So children present with a history of a known ingestion or a toxidrome, or there's some circumstantial evidence, or we need to suspect whenever you have an unusual clinical presentation or sudden unexplained organ dysfunction. A clinical approach is a comprehensive history, physical examination, and diagnostic testing. Normally, for an intensivist, yes, history is important, but in poisoning, it is very important because you need to dig into all these questions. Where has this ingestion happened? How much has been ingested? When was it ingested? Was it inhalation or ingestion? And any household stresses were there, whether it is accidental or intention. So all these questions, a detailed history is very important. A complete head-to-toe examination is required, and I would emphasize especially on pupils, odor, the skin temperature, and bowel movements, especially in poisoning, which we normally tend to miss when we examine a child, so that you can categorize them into different toxic drones, either anticholinergic, cholinergic, sympathomimetic, or opioid or ethanol syndromes. Apart from the routine investigations, we need to do a toxicology screen of the urine, blood, and gastric contents. Do not forget to calculate your anion gap in the blood gas, because high anion gap metabolic acidosis is seen in paracetamol poisoning, ethanol poisoning, and salicylates. When you do a chest X-ray, look for pulmonary edema or a pneumonitis-like picture in salicylate poisoning. Radio-opaque shadows can be seen in iron or heavy metals and sustained release in enteric-coated tablets. And do not forget your ECG. And in the ECG, do not forget to calculate your QTC interval. Certain toxins do have characteristic odor and characteristic urine color. So always look for these features also. And if you have a methanol or ethylene glycol poisoning, calculate the osmolar gap. So the principles of management are stabilization in emergency room, decontamination, finding an antidote, and enhancing the elimination of the drug or toxin being exposed to the child, either by ingestion or inhalation. So in the decontamination, what are the various methods we can do? By activated charcoal, gastric lavage, Goldbauer irrigation. Nowadays, syrup of Epicap or catharix is not there. If you have to enhance the elimination of the drug, either you can do urinary alkalization, or you can do hemodialysis, plasmapheresis, hemoperfusion, or exchange transfusion, and you need to find out if we know what the toxin is, then the appropriate antidote. So gastric, brief about decontamination, GI decontamination. Gastric lavage and activated charcoal. Gastric lavage is contraindicated when you have an unprotected airway or hydrocarbons or corrosive poisoning. Activated charcoal also, certain poisons like iron, hydrocarbons, pesticides, and solvents, there is no role. Whole power irrigation has got a very limited role, especially when there are large ingestions of sustained release tablets and heavy metals or illegal drug packets, which is very less likely we see in an Indian scenario. So the American Academy of Toxicology has said that gastric lavage is not routinely recommended. If you do it within 1 hour of ingestion. Similarly, single dose activated charcoal has got no role in poisoning, no clinical benefit. If you do, try to do it within 1 hour. The drug elimination can be done by urinary alkalization or hemodialysis. Urinary alkalization, you can add soda bicarb to your IV fluids to ensure that the urine pH is more than 7 and urine output is around 2 to 2.5 ml per kg per hour, especially helpful in case of salicylate poisonings and phenobarbital poisoning. Hemodialysis can be considered in case of methanol poisoning, salicylates and theophylline, and anti-epileptics like valproic acid and phenobarbital. So I'll just go through briefly 2-3 cases with respect to their toxidromes. We had a 2-year-old child who came with irritability and respiratory distress and fever for 1 day. On examination, this child was febrile, was tachycardic, hypertensive, and pupils were dilated and reacting to light. So there was a psychiatric disorder in the grandmother. So this child basically fits into the sympathomimetic toxidrome. The child has mydriasis, tachycardia, hypertension, and diaphoresis. Think of sympathomimetic drugs like amphetamines. So in this child, decontamination was done as the child was presented early, fever was controlled, seizures were treated with benzodiazepines, and hypertension was controlled with diuretics and NTG. In case of poisoning and you have seizures, the initial drug of choice is benzodiazepines and phenobarbital. Phenytoin is rarely used. Similarly, we had one more child, a 4-year-old child, who presented in the emergency room at 5:30. He didn't wake up from his afternoon sleep. And on examination, he had a GCS of 8. His pupils were dilated and reacting to light. He was warm, tachycardic, and hypertensive, and he had a huge palpable bladder. And there was a history of epilepsy in the grandmother. So in such a presentation, we normally, all through our medicine and post-graduation, we are very much used to mnemonics. But you think of an anticholinergic toxidrome where there's mydriasis, dry mouth, tachycardia, hypertension, and fever. There was history of epilepsy in the grandfather, so he was taking carbamazepine. And in this child, we had intubated and carbamazepine levels were sent and they were positive. Activated charcoal was administered. There are few poisonings where multi-dose activated charcoal has got a role, especially in sustained release carbamazepine tablets, dapsone, phenytoin, and salicylates. We had a 10-month-old boy whom we transported from a referral center. There he was intubated in view of respiratory failure. He presented with gastroenteritis and transported by our team. So on examination, he was found to be very floppy, pupils were wing point, and excessive oral secretions are there. So this makes us think of a toxidrome like a cholinergy. This child did not have any previous illness, cough, cold, or fever to think apart from the routine infection. It made us suspect cholinergic toxidrome in this child because mother gave a history that they are used to keeping rice bags on the floor and they're spraying pesticide around the rice bags. So always look for muscarinic effects or nicotinic effects. Sometimes they present only with central effects when there is cholinergic toxidrome. So this child, mechanical ventilation was continued, atropine infusion was started, and the end point for stopping atropine was drying of secretions. So the gastric aspirate sample had shown lindane, which is an organochlorine pesticide. So a brief approach or a brief this thing, whenever we face with a toxidrome and you suspect a poisoning, look at the child's pupils. If the child's pupils are pinpoint and you have hypoactive bowel sounds, think of opioid poisoning. If the pupils are pinpoint with hyperactive bowel sounds, think of agents with or a cholinergic toxidrome. If the child has got normal pupils, normal skin temperature, hypoactive bowel sounds, think of sedatives or hypnotics. If the child has got dilated or mydriatic pupils with high-grade fever or child is flushed and the bowel sounds are hyperactive, think of sympathomimetic drugs, or if it is hyperactive bowel sounds, think of anticholinergic agents. So to sum up, whenever we first diagnosing poisoning, yes, have a clinical suspicion as we have discussed if there is a toxidrome or a circumstantial evidence or unusual presentation. So the initial life support phase is ABC, 3D approach, 3D and EF approach. Maintain the airway, intubate if the GCS is less than 8. Support the breathing and circulation. 3D means assess the disability, especially look at the pupils and the reactivity. Think of giving drugs in the emergency room like dextrose for hypoglycemia, for opioid poisoning naloxone, and decontamination can be ocular, with copious saline lavage, especially in organophosphorus poisonings. We have to remove the clothes of the child, wash the skin with copious water and then soap and water, a GI decontamination by activated charcoal or gastric lavage, and do not forget to take the ECG and always check for temperature, fever, and try to find an antidote. After the initial life support phase comes the evaluation, the phase of eliminating the drug or an decontamination phase and supportive phase. So here, a history and detailed physical examination is very important. A complete head-to-toe examination with pupils, powder, and mouth, looking for corrosive lesions and bowel zones, which we tend to miss when we do our examination. A negative toxicology screen does not always rule out a toxin exposure. Try to fit the child into a toxic room and continue and see if there is a role of GI decontamination and enhanced elimination by urinary alkalization, hemodialysis, and an antidote. So there is a supportive care. There's a huge list of antidote which we are not going to go through. We always have AIMS helpline center which is available 365 days, and you can take their support to find out if there is a need for an antidote. So next we are coming to another major preventive problem, which is pediatric burns. Burns in children is associated with high mortality and crippling deformities. There is always pain because of frequent dressings. It is catastrophic to the family, cost burden to the family, and there is always long-term rehabilitation and cosmetic disfigurement. So in children, the etiology of burns could be thermal, chemical, or electrical, and the most common pediatric burn injury is the scald injury. So we have seen pictures of child with a flame injury, a scald injury, and an electrical burn. It's always important to classify the degree and depth of burn because we can prognosticate the healing based on the degree and depth of burn. In superficial burn, it's only the epidermis is involved and it heals in 7 days. Whereas the partial thickness, which is both superficial and deep, involves both the epidermis and the dermis. So the healing time is somewhere from 14 to 21 days. But if you see a third-degree burn or a full thickness burn, this burn does not heal and requires skin excision and grafting. Whenever there's a burn injury, there are 3 zones: a zone of hyperemia, followed by stasis and coagulation. When we try to stabilize this child and resuscitate the child, our aim is to improve the zone of hyperemia and prevent it to go into the zone of coagulation, which is irreversible. When more than 30% of the burn surface area is injured, there's always an exacerbated systemic inflammatory response syndrome. Capillary permeability decreases, myocardial depression happens, and the children are in burn shock. Burns is always associated with a high metabolic rate and depressed immunity state. So pediatric burn management is again a multidisciplinary approach with the initial stabilization in the emergency room, fluid resuscitation and electrolyte management, taking care of the burn wound and debridement, addressing burn nutrition, pain management, and long-term rehabilitation. So with a few case examples, we'll go through how we address this multidisciplinary approach. It's always before starting burn fluid resuscitation, it is important to estimate the burn size. So there are various charts in literature, Dunton, Browder, Rule of 9, Palmer. Recently, people have introduced computerized models in 3D photography. Palmer method is easier in children for whose total surface burnt area is less than 15%. Always for partial and full thickness burns, calculation needs to be done. What we commonly follow in the unit is Dunderberger chart. But the problem with this is a little bit cumbersome, but it is very accurate in estimating the burn wound size. Children with burns can be managed in outpatient if they have a clear airway, the burn wound is small, no fluid resuscitation is required, less than 5%, and they can eat well and drink well and family understands the plan. So when should we refer children to burn referral center? These guidelines have been established by the American Burn Association. Whenever you see a partial and full thickness burns more than 10% of body surface area in children less than 10 years, or more than 20% in all the age groups, or you have an electrical burns, a chemical burns, inhalation injury, burn associated with trauma, and burns associated with pre-existing medical disorders. And similarly, children admitted in hospitals who do not have a dedicated intensive care team, isolation facilities, or equipment for PICU, it's better to refer them to burn wound referral center. So we have a 1-year-old child who presented with hot water scald burns. He received fluids at the referral hospital and was transported to us. So his airway was maintainable, he was tachycardic and tachypneic, he was crying in pain, he was hypothermic, and he had more than 50% of scald burns, and also had facial burns and burns involving the head and neck region. So this child was stabilized in the emergency room. Any emergency basic, we have to follow the ABCD approach, and C-spine protection is also important in burns. Whenever we see inhalation burns or we see a child with hoarseness of voice, stridor, or burns involving the head and neck region, think of intubating, used a cuff tube. A detailed head-to-toe examination is needed, and a detailed burn wound estimation of the size is also very important for determining the fluids and managing the burn wound care. So this child had to be underwent a collagen dressing, had to be intubated and ventilated because the child had airway edema, had burns involving the whole of the face and the upper torso, and fluid resuscitation was started with Parkland formula. So we use Parkland or revised Brook formula, where we initially give crystalloid of 3 ml per kg of percentage of burn surface area of RL plus maintenance fluid. And these fluids should be given half of it in the first 8 hours from the onset of injury, and the second half over the next 16 hours. There are various other formulas in the literature which are a little bit cumbersome to use. The most commonly used is the Parkland formula. So when it comes to resuscitation of fluids in burn fluid, what are our endpoints? Because over resuscitation has got its own problems. It causes intra-abdominal hypertension, compartment syndrome, pulmonary edema. If you don't resuscitate burns adequately, the burn shock will progress, cause multi-organ dysfunction, and the burn wound, which is just superficial or partial thickness, can become full thickness because of the zone of hyperemia will go to zone of stasis. And so it's always better to resuscitate as per the needs of the patient. So our clinical endpoints will be hemodynamic variables and urine output. And whenever you see more than 30 to 40% of burn surface area involved, try to do invasive hemodynamic monitoring by arterial line and CVP line. Burn shock is hypovolemic shock. It does not need inotropes or vasopressors unless there is myocardial depression or there is some sepsis with fluid refractory shock. There is no major role of colloids in the first 24 hours of burns, but it can be considered after 24 hours. We had one more child, a 10-year-old child, during Diwali, quite common, all of us see in the Diwali season, had a flame burns, came to our unit 10 days later, and she presented in hypotensive shock. Her airway was maintainable, she was in respiratory failure, she was in hypotensive cold shock, and she had extensive burns, 65% of flame burns. And by this time, the burns were become mixed burns with burn wound infection, and she was in septic shock. So this child was stabilized with volume and required inotropes and vasopressors, required broad spectrum antibiotics, wound debridement, and pad dressing was done. Subsequently, the next 24 hours, she was in multi-organ failure, had cytokine storm. She also underwent CRRT with heme adsorption therapy. So sepsis and burns is a different problem because the skin integrity is lost. There's continuous exposure to inflammatory mediators. They're in a persistent hypermetabolic cyst-like state, and their temperature is always reset to 38 degrees in children with burns. They have persistent tachycardia, tachypnea, and leukocytosis. So the American Burn Association has laid down certain criteria to identify sepsis versus burn wound SIRS. So if you see tachycardia, tachypnea, thrombocytopenia, or feed intolerance, any three of the four criteria, suspect burn wound infection or sepsis and burns, and establish the infection by positive blood cultures or identify a pathological tissue source, or if there's a clinical response to antibiotics or antimicrobial, then it says that there has been infection. Infection in burns is not only because of burn wound, because of respiratory tract infection. It can happen because of gut bacterial translocation, because of devices related infections, as well as burns itself is an immunosuppressed state. Burn wound infection, there are certain categories in that. If there's a burn impetigo, all it needs is a wound cleaning. If there is a burn wound cellulitis, it needs topical antibiotics as well as parenteral antibiotics. If there is burn related surgical wound infection, it needs debridement with antibiotics, can consider antifungals. But if there is an invasive burn wound infection, it needs debridement, antibiotics as well as antifungals. Nutrition is as important in burns as initial stabilization, fluid resuscitation, or prevention of infection, because after the initial hypometabolic phase, there's a hypermetabolic phase where the resting energy expenditure increases because of a catecholamine rise, and there's a catabolic state, loss of muscle protein. So it is very important to do early and aggressive feeding to address the hypermetabolic phase. Certain drugs have been tried like growth hormone, propranolol, but many studies have shown that there is no clinical benefit. Early and aggressive nutrition does help in addressing the hypermetabolic phase. So generally, we try to provide them 1.5 times their REE and 2 to 4 grams of protein. Even the requirements of your micronutrients and multivitamins is also twice the RDA. And there are various formulas also to calculate the nutritional needs in this child. Addressing pain is very important because if pain is not addressed, it prolongs the healing and post-traumatic stress disorders. And the pharmacokinetics of many of these drugs are altered because there is unpredictable fluid shifts, renal failure, and hypoalbuminemia. And these children undergo multiple dressings, wound excision, and debridement. So use an analgesic which is easy to use, short-acting, and has got a rapid onset of action. Also consider non-pharmacological measures like distraction techniques, biofeedback techniques, cognitive and behavioral techniques. So this is what we do in our unit. We have a dedicated negative pressure isolation rooms with one-to-one nursing, a bundle approach to prevent infections. We use autoclave bed sheets. We do early burn wound excision, and we follow an antibiotic stewardship program and a PCT guided therapy for de-escalation of antibiotics. This is our experience over the last 3 years. We have almost 70% of children who presented with burns more than 15 to 30%, and the mortality is less than 5%. To sum up, burns need a multidisciplinary care, around-the-clock service provided by the ICU and the plastic surgical care team. We need early biological dressings and early burn wound excision, adequate fluid resuscitation, not over or under resuscitation, strict infection control program, early enteral nutrition, and pain management is what a burns needs. It's not only the initial fluid resuscitation. All of these also do help in improving our results in managing patients with burns. So with that, I would like to conclude my talk. Thank you. I think at the end of the session, we'll take up the questions. I would like to invite the next speaker.
Any questions?
I think in the end, we'll take up the questions. So I'd like to invite Dr. Parag, Senior Pediatric Intensivist, for the next talk.
Stop the screen share. Parag, escape.
Base. It's not going on. I'm not able to. Not coming there.
Yeah, you can close it here.
We should have.
Close it.
Yeah. Okay. Now, I'll open
One second. Yeah, open it, and then I'll share it. One second. Go back to Zoom now. It won't reflect. Just cross it once again. Sorry, cross it. Again, share. One second. This is coming up repeatedly, so I'll just put this like this. And let me just set this because this. Please. You're good?
Yeah, good, thanks. Good. So thanks for giving me this opportunity. So I got two topics: polytrauma and raise ICP. Itself, you can say polytrauma is itself a big topic, and ICP, but I'll try to concise and we'll go through it. So what we see in polytrauma, which is very important, is we need to have a structured approach, because there are so many things happening at the same point of time. It might be a trauma related to the brain or liver or any other organ. So you have to be actually taking care of multi-organs simultaneously. At the same point of time, there is an algorithm called as an ABCDE, which you are actually every point of time going through that and reassessing whether whatever the intervention you have done is actually done a benefit to the child. So what things includes are primary survey, secondary survey, then you have an adjoint survey. We will talk about it. Then I'm going to talk a little bit about massive blood transfusion protocol and sequential analysis. But at the same point of time, I don't want it to waste too much of time in actual polytrauma management, because if you see, it itself is a very big topic. So we know it's a leading cause of a death, and there are a lot of people says in a polytrauma, whether you're going to live or die depends upon where you have an accident. So if you are near the hospital, there are high chances of actually you are leaving, and if you're away from the
hospital, more chances. And what we called as a golden hours, maximum people die, if you see, in the first 2 hours, or most of them have a peak in the first 30 minutes. So these are the couple of hours which are very important, and we have to target our intervention based on these hours, because if you do that, you'll be able to reduce the mortality by almost 30 to 40%. So how pediatric traumas are a little bit different than the adults? We know that they have a different physical, psychological, as well as physiological categorization in the form of probably a car running into the road might hit an adult on the abdomen or upper chest. But if you see in the kids, they might actually rolled over. So it all depends upon the adults might resist the injury. So when any child coming with the polytrauma to your emergency, it's very important to understand how the mechanism of injury, because it could be a high velocity, low velocity, or a low velocity, a very high intensity injury. So all those things are very important. And most of the time, adults try to resist the injury, which is unlikely in the pediatrics, where they are unaware of the surroundings. So they tend to have a more injury as compared to the adults. So this is, so we know we have been told long back, and every time we actually discuss about the same thing, ABCD approaches. Same thing happens in, I would say, in trauma, except one thing which is very, very prominently encountered in a trauma is the C-spine. So we consider C-spine early before any other intervention. So you have area where actually you can prepare for taking care of this patient. Then you have a primary survey, secondary survey, and then revaluation. So let's talk about it. Where to treat? So we know that most of the time this patient goes to the nearby hospital in the emergency room or sometimes clinics, but there are places where actually has to be admitted in the trauma center. So this is a score devised by the New Zealand and Australian Society of a Trauma, where they have found out if the lower the score than 8, they have utilized weight, airway fracture, cutaneous manifestation, and other organ injury. If it is less than 8, has to be treated in the pediatric trauma center. And if you see all over the West, I would say North America as well as European countries, you have a separate pediatric trauma centers. So what 3 things are important is you have to take care of a danger to the life first. It would be anything. It might be just an injury. Before going to the airway, you can see that the artery bleeding torrentially. So you'll not actually take care of an airway. You just go and stop the bleeding. So whatever is danger to the life to be first. You don't need a definitive diagnosis to treat anything, and detailed history is complementary. So you have to make it sure that your aim in the trauma is a physiological stabilization. You are not worried about any other thing at that point of time. So airway, as we told, airway and cervical spine control, breathing, circulation, disability, and exposure will go with each of them significantly. So assessment, does the child have a patent airway? When the child comes, you have to see whether the child is breathing fine or not. There might be a trauma to the ribs or hemothorax or a pneumothorax. The breathing is looking fine or not. There might be a fracture of the facial muscles, okay, bleeding into the nose, or there would be a dental injury also. So you have to make it sure that your airway is clear. And whether the child is able to protect the airway, there might be a multiple reasons that the child is not able to protect the airway, as we told, fracture or a level of consciousness. Depending upon that, you have to think about whether the child needs an advanced airway or probably a small maneuvers by which you can actually open the airway. It's very, very important because they are in a compensated phase. Here, a small change into the airway or a small decrease in the oxygenation might percolate the things, and child will go into the decompensated phase. So always suspect by spine injury. So invariably, any trauma patient with or without injury to the neck or spine, you have to think about a neck injury, because there are a lot of times we have missed and found out that ultimately they'll land up into the spinal, I would say, complications like paraparesis and quadriparesis. So rigid collar, a lot of things changed. We have a very small pediatric collars available, but a lot of times we don't have a very, very small collars available for the smaller kids less than 1 year of age, where we can use our imagination and devise a proper hard collar. So few jaw thrusts to prevent actually, I would say, secretions entry and opening the airway. This is also very important. And we have to know how the jaw thrust has to be given, because we have to prevent the mobility at the atlantoaxial joint as well as the initial cervical joints, because there might be a destabilization of that joint and the child might land up into a problem. So breathing, ensure adequate oxygenation is there, ventilation. Most of the emergency unit, we have a saturation monitor, heart rate monitor. You can start doing that. Be aware of the pneumothorax and hemothorax, which is associated with the polytrauma. Surgical intervention, a lot of time these patients, they might not be able to breathe and there is a desaturation. So in that situation, you have to just get a tube in so that they can have a better breathing. And always look for the efforts of breathing, how they are breathing, efficacy, whether it is translated into improvement the saturation, and effects of the respiratory inadequacy. So it's like a continuous process. The child had a problem, you intervene and reassess whether the child requires another intervention. Breathing, intubation. So there are two indications for intubation. One, I would say the child is going for some elective surgery and child requires some intubation. And second thing, most of the time, I would say respiratory insufficiency related to the polytrauma. Third thing, if the child is having a raised ICP features in the form of GCS less than 8, or again, the child requires any neurosurgical intervention. Circulation, very important, because most of this patient might be excanguating and bleeding into the tummy, or probably let it be other side of the body. So maintaining an organ perfusion is very, very important. And while doing that, you have to have a close watch on heart rate, blood pressure, CFT, how the child is able to, the bleeding has stopped or not, any other intervention is required or not. And we have to make it sure that they are open wound or closed wound, because the management will define differently. Because if it's an open wound, definitely will require a pressure. It is a closed wound, there are a lot of times we have to go for the laparotomy. So control bleed, volume replacement has to be continued, which will be normal saline and fresh blood or PAT RBC. Reassess whether the child is improving or not. Make it sure that you try for an IV line for approximately 90 seconds. And if you won't get the line in the first 90 seconds, you go for an IO. And remember, any blood products, anything can be given through the IO. So you are pretty sure that IO is going to help you. So shock wise, when the child comes into the emergency and you feel the child is in shocky, we know the differentiation about shock and I would say compensated and decompensated, but make it sure that any doubt, go for the higher level of a treatment rather than a lower level of treatment. Okay, so always in the emergency, we are over treating rather than under treating. So you have a hypotension, give a fluid bolus, make it sure that you are keeping in mind, these are the kids who requires a lot of saline or blood products. So you are taking care of a temperature and probably problems which happens with that in the form of a coagulopathy or post-transfusion coagulopathy. So don't wait for hypotension to happen, give warm fluids, make it sure that there is a balanced resuscitation, you are not over or under resuscitating. If the shock is corrected, in between there is a pathway where actually we do a E-fast, and if you see the child is having a shock and an E-fast is a positive, the child definitely goes to the OT. And E-fast is negative, you keep on resuscitating this child until they are actually not improving. In the sense, you can see shock is persistent, you have given O negative blood or probably a matched blood, and child has improved, that's fine. But the child has not improved, then the child goes for the damage control surgery, depending upon the identification of an organ where the child is bleeding. So child comes into the emergency, bleeding, shock, okay, E-fast done, E-fast positive, go into the OT, okay, E-fast is negative and you gave a blood, but the child is still bleeding, you try to identify the cause and probably the child will go into the OT depending upon the identification of the cause. So this is called damage control resuscitation. Now, this is a commonly used terminology in resuscitating the trauma patient. You see, most of them are targeted approaches. You can see active bleeding control to prevent a further blood loss, hemostatic resuscitation in the form of giving a lot of blood products, and I would say isolating the blood product required, tranexamic acid early utilization, monitoring which is going simultaneously, and you can say you have to limit the number of a blood product as well as saline, because ultimately these patients are going to go for traumatic DIC. So you have to make it sure that you are not pushing too many things, and you can see there is a triad. You have a trauma, acidosis is going on because you're pushing a lot of bloods, and at the same point of time they're going into the anaerobic metabolism. Then you have a hypothermia because again low temperature fluids are getting in, and coagulopathy. So if it sets in, it is very difficult to come out of this scenario, and this is a common scenario you see in a lot of I would say multi-polytrauma patients as well as in liver transplant patients where they receive a lot of blood transfusion. So massive transfusion, different I would say definitions are there, but anybody who is requiring more than approximately 40 ml per kilo in the first 24 hours is taken as a massive transfusion. But there are different I would say definitions available, but more than 40 ml per kilo has to be taken as a or sometimes they say twice the blood volume who is requiring the blood transfusion. So this is what you call cascade, which sets in when you give a lot of blood products. So you have a trauma, you have a hemorrhage, and there is a simultaneously inflammation is going on. You are resuscitating the child. There is a dilutional hypothermia. Calcium goes down because a lot of blood product has been given. Acidosis is there, and you have a shock, acidemia. So all those sets in is coagulation related DIC, and you can actually land up in a situation where you're going for a surgery, but the child is continuing to bleed in spite of appropriate resuscitation. So disability, very important because it might be related to the CNS. So make it sure that you have a clear understanding what the child is having. You can use a different scale, GCS or AVPU. Make it sure that if there is a smallest doubt, or seizure or unconsciousness, consider it as one of the seizure event, and probably you might land up in giving an antiepileptics. And concealed injuries are also very important when you are talking about an exposure. Sometimes they might be bleeding into some of the places where actually you are not looked for, and unrecognized injury, which might be sometimes has to be addressed early. So this is called as an adjoint primary survey. This is called as adjoint primary survey. So once you stabilize this patient into the emergency, and simultaneously there is another thing you have to think about is stabilizing this patient and going to the PICU. Then comes the role of an adjoint primary survey. So you remember, you don't need an X-ray emergency into the managing this patient. So other things which are required is X-ray, EFAST, ECG if required, echo, because you can have a tamponade sometimes with high velocity injury, blood test if required, if you got an IV cannula, PICU transfer, and bowel and bladder care. So these are all adjoint survey. Remember, ABCD comes first, and if you are able to go through it, any point of time, actually the child is deteriorating, you're going to follow the ABCD approach again and again till the child stabilizes. And remember, there is no scope of a secondary survey unless otherwise child is absolutely stabilized. The secondary survey includes examination, making it sure how things has happened, as well as taking care of the other injuries and a systemic examination. So this is a just brief about the polytrauma. Now about traumatic brain injury, which is one of the commonest injury you see in pediatric population, mainly related to the high velocity injury, falls, or probably a roadside accidents. So short, we know about intracranial pressure. So we have three things in our, I would say, vault: brain, blood, and CSF. Any of the things go here and there, it has to compromise the brain. So let it be there is a CSF pressure up or the blood flow goes up. So ICP will go up and actually will decrease the brain matter. So it's a basic understanding between the two doctrine, which is Kelly-Monroe and Burrow and Weed. And this has been really very, very clear with respect to the physiology. So what happens in a primary brain injury, so you know that there is a primary brain injury at the same point of time, neuronal disruption, which is definitely related to the injury. You can have infection also, but here we are talking about traumatic brain injury. There is a blood-brain barrier injury. Then neuronal disruption causes cytotoxic edema, intracranial pressure goes high, and what happens? So blood-brain barrier injury is also there. There's a vasogenic edema. So two edema coming together. What happens is there is a less the swelling is there. There is a less space. So it started compromising the normal brain. What we call it is a secondary brain injury. And because of that, what happened? The CSF flows goes down. Probably body will try to compensate by decreasing the cerebral blood flow, and you started having an ischemia. So it's a counterplay between all of them: primary injury, blood-brain barrier injury, vasogenic and cytogenic edema. And ultimately in traumatic brain injury, our aim is not to reduce the primary brain injury. Nobody can do that. It has already happened, unless and otherwise there is a surgical cause, like there is a hematoma or a depressed fracture. But the secondary brain injury is the one thing which we have to prevent. And we do all the things, everybody in the world is trying to do to prevent the secondary brain injury. So these are the clinical features where we are able to identify the early features of raised ICP, but make it sure that any encephalopathy in post-trauma patient consider as a sign of a raised ICP unless otherwise proved. Because again, I told you, the emergency, it is better to over-treat than to under-treat. We can't be dogmatic that probably it might be just because he bled a little bit or he is looking a little bit hypoxic. So make it sure that you have ruled out CNS injury. And whatever the things we do in the emergency room, like a CT, will not actually tell you exactly about the axonal injury, or you can say diffuse axonal injury. So make it sure that whenever it is required, MRI has to be done. I'm not talking about an initial resuscitation, but over the time. And remember, hypertension and bradycardia is a late sign. Pupillary changes is also late sign of a raised ICP. So try to identify it early than the late. So these are the few features: increases the chance of increased intracranial volume or causes raised ICP, increase in the carbon dioxide, hypoxemia, acidosis, hypoglycemia, increased temperature, increased metabolic activity. And these are the things which have to target when we are taking care of a traumatic brain injury. So as I told you, avoidable brain injury or secondary brain injury is one thing which we have to do it. Means the primary brain injury, there is no way I can do anything for that. So target your all intervention to prevent the avoidable brain injury. So yes, over the time we knew that we use cerebral perfusion target therapies, and we try to keep the ICP less than 20, and we try to keep the CPP more than 40 to 60. So what we have to remember is we have a centile blood pressure centile. So make it sure that at any point of time, if you don't have an ICP and you feel the child is having features of raised ICP in the form of encephalopathy, what you do is you try to keep the blood pressure around 75th centile. Don't keep it on the 5th centile. So try to keep it on 50 to 75th centile so that the effect of CPP is better, okay, rather than accepting the lower standards. So that can be done easily without knowing the ICP. So this is an algorithm. What you have a neurological examination, signs and symptoms suggest of raised ICP. If it is a resectable mass, hydrocephalus, or a bleed, or a trauma, or a surgical intervention is required, the child goes for the OT. They come out through the OT, depending upon the situation, decompressive craniotomy or ICP catheter insertion. And if those things are not there, what happens is we take care of the airway, breathing, circulation, because it's very important to have a CO2 targeted therapy. Depending upon, so CT MRI has been done most of the times. Even before the child comes to the PIC, CT is done. And we decide whether this child requires any ICP catheter intervention, or most of the center it is not available. What we do is a supportive care. What it includes: head and elevation to increase the CSF draining pressure, head and elevation, head in midline, minimal stimulation, clustering the care, sedation, normothermia, normoglycemia, okay, normovolemia, all those things, and a seizure control to prevent the supportive. Other things which are very important is mannitol and hypertonic saline. Mannitol is a really good drug and has to be used when you feel there is an acute rise in the ICP. And remember that this is not a drug which can be used as a scheduled drug, because mannitol is a very, very good drug, but it actually equilibrates very early with the body and it increases your osmolality. So after around the osmolality of more than 320, it doesn't help that much to the body. Hypertonic saline, yes, you can use up to 360 of osmolality, a good drug, and try to maintain the normonatremia, probably around the 140 to 145. So this is things. So if everything is settling down with the supportive care and hypertonic saline and osmotherapy, things are good. If the things are not getting controlled, so then we are dealing with the refractory ICP where the neurosurgical intervention will be required. So these are the few recommendations from the Brain Trauma Foundations which I have given. So as I told, key CPP, ICP more than 20, and try to keep it at least maintain the CPP more than 40. And remember, try to maintain the blood pressure around 70%. Thank you.
That was a nice presentation by Dr. Bharat. So our next speaker is Dr. Kapil. He is going to talk on algorithmic approach to status epilepticus and status asthmaticus. Anybody having any doubts regarding the topic which is discussed now, polytrauma, traumatic brain injury? If you want to ask anything in a practical, way, we can answer that. So basically, polytrauma, we need to understand that we have a primary survey and secondary survey. Primary survey is just like the primary assessment of PALS, where we go A, B, C, D, E, and go on addressing the problems in airway, breathing, circulation as we see them. Secondary survey is after stabilization of the patient, going into more detail and proper examination of the skull, ears, nose, mouth, neck, spine, chest, abdomen, pelvis, and long bones, to make sure that we don't miss any fractures or any intra-abdominal problems. So that is secondary survey is a new thing in polytrauma compared to what we do normally in PALS. And one more thing is this massive transfusion protocol. We say 1:1:1. Now the recent guidelines say that if you're in a hospital where you can monitor platelet counts and PT, APT, INRs, you don't need to give 1:1:1. Rather than you every 8 hourly or 6, depending upon sickness of the patient, you keep checking your platelets and INRs and then decide on that, and fibrinogen levels.
Yeah, they said it's a tech which is came for the liver transplantation, so they are using tech to see what blood pressure you have to give.
Good afternoon, everybody. Post-lunch session. I'll try to keep you awake with the. Okay. So again, 15 minutes time, 2 topics to cover. So we'll be a bit faster running through the slides. The first one I'm discussing is status epilepticus, and then second would be the status asthmaticus. So first status epilepticus. What is it? It is an acute life-threatening neurological emergency we come across as a pediatric intensivist with quite common incidence of 10 to 73 per 10,000 pediatric population and highest incidence in less than 2 years. Definition. The definition is a 30 minutes time limit, and why it is that will come across. So prolonged seizure more than 30 minutes or no regain of consciousness in between is according to the International League Against Epilepsy 1981, quite old. But again, there is one more thing which comes like 5 minutes or more of continuous clinical or electrographic seizure activity or recurrent seizure activity without any recovery. There means not returning to the baseline between seizures. So practical purposes, we always take it as a 30 minutes cutoff for status epilepticus. The definitions further, what is status epilepticus, what is refractory status, and what is super refractory status epilepticus is a one after another. Status, as we said, 30 minutes or 5 minutes. And refractory status, we give the baseline first benzodiazepine to control the seizures, and then we have one more add-on drug, any drug which is acceptable as an anticonvulsant, and then still the seizures are ongoing. We label it as refractory status. Third one is super refractory status. So fancy names. Again, this continues for 24 hours or more, even after the onset of anesthesia. Is it working? My volume is less. So super refractory status epilepticus is like something which goes on for 24 hours and even more after the onset of anesthesia, induction of anesthesia. So why 30 minutes? Then a lot of decompensatory mechanisms set in after the 30 minutes period in general. So what happens within first 30 minutes, body's compensatory mechanisms do well, compensate with increasing the cerebral blood flow. Cerebral energy requirements are met by increasing oxygen and glucose, increase glucose concentration in the brain, and catecholamine. But as the time goes on, more than 30 minutes in general, the decompensation sets in, and wherein you see the brain getting hypoxic, hypoglycemic acidosis develop, hyponatremia and hypokalemia with DIC. So that's the reason we say so decompensation sets in after 30 minutes in an average. So pathophysiology wise, as already said in the beginning, there is sympathetic overdrive, compensatory mechanism set in with increase in cerebral blood flow, but subsequently, subsequently the sympathetic overdrive gets exhausted, and decrease in the oxygen requirement continues to be like that, but there is a decrease in the blood pressure and the blood flow, which causes hypoxia, acidosis. Etiologic classification, cryptogenic or idiopathic without any pre-existing neurological insult, remote symptomatic with some known history of neurological insult is there with increased risk of seizures. Febrile, we all know, febrile is provoked by fever. Acute symptomatic, again, there is some history of acute illness involving a known neurological insult and progressive encephalopathy, progressive ongoing neurological disease is there. Types, again, depending on what type of seizures, most commonly we see is generalized convulsive status epilepticus, second focal status epilepticus with preserved awareness. Non-convulsive status epilepticus we come across many times in the PIC, wherein we don't see the obvious seizure, but there are electrographic changes, EEG changes in the seizure activities there. Others like absence or myoclonic seizures can also present. Goals of the management. So anything, goal of management is to control the seizures, to terminate clinical, not only the clinical, but electrographic seizures at the earliest. The definite control should be established within 60 minutes of time, within the 60 minutes of onset of status epilepticus. And we all, as a unit policy, should have all our own protocol for management of status epilepticus. and the delay in management causes a lot of AAD refractoriness and then prolonged seizures possibilities. Prevent and treat symptomatic complications along with the associated with the use of anti-epileptic drugs, anesthetic drugs, prolonged unconsciousness, and prolonged PICU stay. So previously used to be first anti-epileptic, second anti-epileptic, third anti-epileptic, but no longer we use that. Now currently the classification is with emergent medications like benzodiazepines, urgent medications, and then refractory therapy like coma. So this is from American Epilepsy Society, wherein they say first 5 minutes, what should we be doing is like any emergency, like maintaining the airway, breathing, circulation, looking at the disability and having the neurological examination, time of seizures and onset, monitoring the vital signs. Herein we give oxygen, give with any oxygen mask or cannula, then initiate the ECG monitoring, wherein we look at the heart rate and ECG. Then check blood sugar levels and then give saline if needed, and attempt IV access if not getting IV access easily, and get some blood samples to investigate for the electrolytes, hematology, toxicology screen, and then if IV access is difficult, IO access. So this should happen in first 5 minutes. It's an emergency line of treatment, and then after the ABC has been stabilized, like giving the head position, clearing the airway, secretions, intubation if required, if the airway is really compromised or respiratory failure is there, and then assisting the ventilation with breathing with the ventilation if required, and giving the oxygen, and correcting the hypotension with saline boluses, correcting the hypoglycemia with dextrose, and getting an IV access and detailed neurological examination. And drugs we commonly use here in the first 5 minutes are the benzodiazepines, which are really ultra short acting lorazepam, or the midazolam, either IV or midazolam can be given nasally or buccally or intramuscular. Then once this is done, we have to see has the seizure been controlled or not, and if the seizures are still going on, next 5 to 10 minutes comes the urgent control of the therapy, wherein various drugs are prescribed. There is no set sequence as such which drugs to be used, but of late most commonly used drugs is levetiracetam with loading of 20 to 30 milligram over 50 minutes, followed by maintenance, can go up to 40. Phenytoin or phosphonatoin is another drug, and phenobarbital followed by sodium valproate. And along with this, here we should have additional diagnostics testing if required and clinically warrants, like neuroimaging, lumbar puncture, EEG monitoring, neurologic consultation, and then pyridoxine if child is less than 2 years old. Then if, as same thing we discussed, the drug medications which we should be giving in the next 20 minutes time. Then if still continues, then it goes into the refractory status epilepticus. Then the repeat boluses of urgent anti-epileptic drugs can be used. Pharmacological coma, here intravenous or inhaled medications, and then mechanical ventilation is something which becomes mandatory at this point of time, with central venous access for better monitoring, hemodynamic monitoring and temperature control. And then here is something we need continuous EEG monitoring. And then 40 to 60 minutes, there is no clear evidence what to do. So many people reuse the drugs to optimize the levels, check the drug levels, and then decide which drugs works better. Have a continuous EEG monitoring, give the medicine, see which medicine works better for which patient, and then go accordingly. So doses wise, midazolam is always an emergency. Diazepam, lorazepam, these are the emergency medications. Doses again 0.15 to 2 milligrams, IM or IV, or buccal can be used. Diazepam 0.2 to 0.3 and lorazepam 0.1, maximum 4 milligram. They all come with some side effect of respiratory depression and hypertension. So vitals monitoring is equally important when we are using these drugs. The phenytoin standard doses we've been used for 20 milligram loading, followed by the maintenance or infusion, not more than 1 milligram per kilo per minute. And then phosphonotyne similarly, then phenobarbital standard same doses, and we had to keep a watch on the airway, breathing, and the hemodynamics while we give these medications. Roll-up EEG, continuous EEG or roll-up EEG to identify the psychogenic status epilepticus, which is not very common to come across, to identify the non-convulsive status. There is the role of EEG. Many times we see the patient comes with status epilepticus, settles down, intubated on some midazolam, but we don't know whether the child is still seizing. The EEG is only going to tell you, do we have subclinical seizures or non-convulsive status? And also it helps to look, identify the burst suppression when continuous EEG is used. So doses recommendations for the suprarefractory status epilepticus, again midazolam infusion, high doses up to like 12 to 24 micrograms per kilo per minute. Thiopentone, similarly high doses to induce medication induced coma. It causes significant hypotension, so should be worried about it. Should have enough intravascular volume filled in. Phenobarbital and ketamine also are used for a similar purpose. And again, neuroimaging once the child has stabilized, CNS infection considered in less than 6 months without fever. So it's a multiple things we need to look into that when we are having a child with status epilepticus. Not only the controlling the seizure, which comes as the first part, then subsequently we need to identify is there anything more we need to do, and then identifying the super-refractory or refractory status epilepticus. Thank you. Next part of the talk would be again the one more. How do you come on the?
Yeah, just click on OK. Click on OK.
This OK.
The OK here.
Yeah.
Yeah. Now open your presentation from the folder.
From the folder, yeah.
Now go to Zoom.
Yeah. And then go back to Zoom, okay.
Close this because there will be a conflict and the screen will be starting.
This, yeah, they both are same.
Yeah, that's what happens. So it goes static. So close this presentation. So now go to Zoom. Share from there. Yeah. Now go to the slideshow. And before you start, no, it has to come up as share. It's not coming up. Just check. Yeah. So now just go to just move the cursor. It has to drop down. This has to reflect even when you're sharing. Stop screen share. Just leave it.
Let's see where the issues.
So to go here. And after you do this work, ఇది చేశాక ఇక్కడ హైడ్ ప్రెజెంటర్ వ్యూ అప్పుడు ఇట్లా వస్తుంది. So whenever you speak, make sure this comes on top.
So then only the people.
Then
can
only
see.
it's online. Else it's not online. It's only visible to us.
Okay, so next topics for 7.5 minutes is a status asthmaticus. Again, when asthma is something which we all come across quite frequently. So it's a chronic inflammatory disorder characterized by airway obstruction due to upper airway hyperresponsiveness. And what happens is hypoxia and hypercarbia. In the beginning, hypocarbia, later on hypercarbia. So why does hypoxia happen is because of the airway obstruction and VQ mismatch. And in the beginning, CO2 levels rise to obstruction as obstruction worsens, and subsequently, am I still not audible? And subsequently, once as the child baby gets tired, the hypercarbia ensues because of the dead space effect. What are the cardiopulmonary interactions of the asthma or acute severe asthma? First thing which happens is the decrease in the vein is working. Hello. Is the decrease? Now it's working. Decrease in the venous return due to fluctuations in the pleural pressure. So increase in the pleural pressure reduces the venous return, which eventually will lead to the decrease in the cardiac output and systolic blood pressure. Also, there is a phenomenon everybody knows about is pulsus paradox, where exaggerated variations in systolic blood pressure with breathing. The high lung volumes will increase your PVR, pulmonary vascular resistance, as well as right ventricular afterload, and the normally passive expiration becomes active process in the asthma because of prolonged expiration of expiratory obstruction. Then acute subacute episodes of progressive worsening symptoms, airflow obstruction, which we just discussed, and often worsens during sleep. This is normal asthma, not in status. Immediate management is rapid evaluation of severity, and then presentation varies with the severity and the age and triggers. So severe exacerbation that doesn't improve with the standard therapy is called status asthmaticus. And then all that wheezes is not asthma as well. All asthmatics may not wheeze. This is essentially important to understand that, and even the degree of wheezing does not correlate with the severity of the asthma. And even in fact, the presence of pulsus paradoxus, which correlates well with the asthma severity, and noisy chest is in fact a good sign because there is some air going into the lungs and not completely blocked. Or if the breath sounds are absent or decreased, that's more worrisome because that means the air not much air is going to the lungs. So it's clinical points to remember in any child with severe breathlessness with history of asthma. High risk factors to know: any child coming to the emergency room or clinic having background history of asthma, the previous sudden deterioration is a high risk that child might deteriorate. The past PIC admissions, previous respiratory failures with needing mechanical ventilation, and then having on systemic steroid courses earlier. These all things will tell you that this child is going to deteriorate quickly, and then we might have to do something more or refer. History again is a standard thing for all the current medications, dose, devices which they are been using. The medications history with dose and devices which they've been using, any recent changes in the dose or potential triggers. Response to therapy is important. Again, not everybody responds to each medication which being used for asthma, and the onset of recurrent exacerbation and frequency and severity of daytime and nighttime symptoms. So how well controlled is the asthma, that will tell us all these things. Physical examination again is important to assess the severity of the asthma, as well as how much is the work of breathing, and then a child in impending respiratory failure or is being managed, is been coping well with this hypoxia and the distress. So use of accessory muscles, as we see in any child with to assess the respiratory distress, air entry in both the lungs, and wheezing. Level of alertness is very important aspect of the asthma, status asthmaticus, because the child in the status asthmaticus should be wide awake as long as he's maintaining his oxygenation and clearing his carbon dioxide. The minute he gets fatigued and tired because of hypoxia or hypercarbia, he will be very drowsy, sleepy, and that's a really bad sign in a child with asthma. Ability to speak in full sentences to assess the severity. There are many ways to do that. Agitation, drowsiness, confusion are rare clinical features, but they indicate cerebral hypoxemia. Spirometry and peak flow meter are not useful in the acute exacerbation settings. Investigation standard: look for the infection, do CBP blood culture, look for the electrolytes to see the hyponatremia because of dilution or dehydration, hypokalemia. Chest X-ray not routinely indicated, but I know all of us do that. It's more for a look at is there anything more than asthma we're dealing with sometimes. And then PICU admission required, then definitely when it's needed. And then all the status asthmatics, they come to PICU. ABG, which is something definitely we need, that will tell you about the degree of hypoxemia, degree of hypercarbemia, and that will tell you the response to your treatment with subsequent ABGs as well. Lactic acidosis developing. Metabolic acidosis is not a good sign, and that means the decompensatory mechanisms are setting in. The child is getting fatigued because of the overuse of respiratory muscles. Categorize and see, again, depending on the work of breathing, level of alertness, ability to speak, use of accessory muscles, air entry in both lungs, presence of all the signs which will tell us about the severity. This some scoring is developed, this pulmonary index score or Becker asthma score, which uses the respiratory rate, inspiratory and expiratory time ratios, how prolonged is the expiration, wheezing, and accessory muscles use. So in general, the scores more than 4 are moderate and more than 7 is severe asthma and does need in the ICU admission. Again, severity table divides differently and then can be used. You can find many tables like this. But what we look at is mental status, physical examination, exhaustion, like use of how effective is the breathing efforts, then how these be able to talk or not, oxygenation, and then air entry on both sides, and wheezing and ABG. Management is always being around oxygenation, giving lot of oxygen, beta agonists like salbutamol and steroids. Along with that, some more medications will be there. Mild to moderate exacerbations, target would be to keep your saturations more than 94, to give plenty of oxygen, either by any means like NRM or the simple face mask oxygen or cannula, but aim saturations more than 94. Salbutamol for 20 minutes back-to-back nebulizations for 3 times at least. Doses like less than 6 years, 2.5 milligram, more than 6 years, 5 milligram. Oral steroids, prednisolone in mild to moderate is useful, but steroids takes its own time to act, and then meanwhile salbutamol helps us to buy some time. Reassess every 20 minutes. This is very important. Reassessment of any child with moderate exacerbation, because the minute you think, even after giving salbutamol nebulization, even after giving oral steroids, if the child is not improving or in fact is worsening, means you need to be one step ahead of the disease process. Severe exacerbation, again, IV access, high flow oxygen. I think oxygen will come before IV access. Then high flow oxygen, then continuous cardiac and oxygen saturation monitoring, IV fluids and correction of the shock. Standard A, B, C treatment has to be there for any child who comes in emergency. Then steroids, every 6th hourly or 12th hourly later can be changed. IV salbutamol, which is not available in India, so we use many times IV aminophylline, and continuous aerosolization, aerosolized nebulization with beta agonist salbutamol with ECG monitoring. Magnesium sulfate has good evidence that it works really well with many asthmatics, especially bigger children, given IV with the loading of 20, good dose of 20 to 50 milligram per kilo. And ipratropium is bromide, something which is given as a nebulization. Terbutaline infusion used to use that. I not use it for long time now, but something which can be used is 0.05 to 1 microgram per kilo per minute as an infusion, and then aminophylline infusion, which is commonly used. So oxygen, nasal cannula, mask, or rarely head box. O2 therapy should be titrated against pulse oximetry. Antibiotics not routinely indicated unless you have evidence for infection or you're thinking infection has triggered the asthma. But it's good to send a culture, start antibiotics, and then reassess the need for antibiotics. Other things like spirometry, mucolytes, chest physiotherapy are not recommended in the acute phase. Hydration maintaining, hydration status is very important to avoid the dehydration and electrolyte disturbances with so much of beta agonist nebulizations. Beta agonist is the mainstay of therapy, inhaled, subcutaneous, IV, or oral, but salbutamol or terbutaline are generally preferred. Continuous nebulization is superior to intermittent doses is been proven. And IV salbutamol we don't have in India. Continuous nebulization is defined as continuous aerosol delivery of beta agonist medication with large volume nebulizer or small volume nebulizer with infusion pump or sufficiently frequent nebulizations. Intravenous in patients who are unresponsive to continuous nebulizations, and subcutaneous is rarely used in acute settings. They all come with some adverse effects, especially the beta agonists. They are like tachycardia, hypertension, diastolic hypertension, and changes in the QT interval. Most commonly, hypokalemia and hyperglycemia. Salbutamol causes all those things, and excessive CNS stimulation. Occasionally, the hyperactivity, tremors can happen, nausea, vomiting. Anticholinergics like beta agonists, along with the beta agonists, they are used always in combination with salbutamol or terbutaline. Ipratropium bromide is commonly used, and with nebulized aerosol or MDI with doses. Subsequent recommended dosing interval is 4 to 6 hours. Again, they cause some dry mouth, tachycardia, and flushing. So when we are using these drugs, we should be looking at the side effects as well, because we're using these drugs and more frequently. Steroids, the first time therapy in acute asthma exacerbation. Commonly used steroids is hydrocortisone, but sometimes we use we've been using methylprednisolone and dexamethasone as well, and they help with decreasing the edema and relaxing the airways. But if onset of action is quite late, the maximum effect is seen after 4 to 8 hours. With Alzanthins, we been through aminophylline infusion. It's still been used. It causes a lot of toxicity. Monitoring the levels is equally important if available. Magnesium sulfate, as I said, it causes smooth muscle relaxation, secondary to inhibition of calcium uptake, and it has we see quite a good response to some kids with magnesium. Ketamine for children who are intubated and ventilated is a good sedation, causes some bronchodilatory action. And the reasons, absolute indications for intubation, and as much as possible, we should try and avoid intubation in asthmatics, because it's really very challenging to ventilate these kids. And the absolute indication would be like respiratory or cardiac arrest, very significant persistent hypoxemia causing end organ changes or end organ damage. Rapid deterioration in mental state, again, is related to hypoxia, and no improvement with maximal therapy, which we've discussed. How do we ventilate is different story, with slower ventilator rates, longer expiratory times, shorter I times, and minimal PEEP around 2 to 3, because they generate a lot of atopy. To minimize PEEP, decelerating waveforms are more important. It's more of a detailed ventilation. In inhaled bronchodilators in mechanical ventilator, you can give with nebulizers, ultrasonic nebulizers, jet or ultrasonic type of nebulizer. During mechanical ventilation, again, low respiratory temperature is most likely, MMD 1 to 3 micrometers. Ketamine, we see in vecuronium and heliox, and NIV has got some role, but very risky to put these babies on ventilator again. Sorry, I was rushing too much because somebody was waving me, time up. Are we taking questions now or later? Later. Okay, thank you.
If somebody has any questions, they can ask now also. Yeah, it was a nice presentation. So basically, anybody who comes seizuring in the emergency room should be taken as a status asthmaticus. You can't apply timeline of 20 minutes, 30 minutes, 1 hour. Anybody you see seizuring in the emergency room is a status asthmaticus, and start treatment as per the algorithm shown. And any child who had a seizure and who is a drowsy child now, and the sensorium is not improving even after 20-30 minutes, which it should improve, then you can take as a non-convulsive status epilepticus. That's the main thing. Now the next talk will be Dr. Chetan on DKA. DKA. Folder tha? This one. DKA कहाँ पर? DKA.
Good afternoon, everyone. First of all, many thanks to IAPTCB and Rainbow Children's Hospital for having me here. So, and also thank Farhan that he has only given me one topic and has not asked me to squeeze 2 into 15 minutes. So I'm seeing some students, so I hope this is a more of an interactive one. So DKA, it's a fairly commonly seen pediatric emergency, and the scope of this 15 minutes, we'll see about the definition and how to diagnose and what are the risk factors for complications, and the therapy and the monitoring and complications management. So it is one of the most important mimic of various acute conditions, even in children. So whenever you come across this is on. So whenever you come across any acutely sick child and who has any of these more than two symptoms, you have to either consider or rule out DKA. So these are acute abdominal pain, severe isolated vomiting, breathing difficulty or abnormal breathing, polyuria and polydipsia, and fatigue and headaches. So, I mean, many of the pediatricians who are here, they must have seen children coming to them as pneumonias, as encephalitis, as acute abdomen, and finally diagnosed to be having DKA. So, a random blood sugar should be considered as a sixth vital sign in any acutely ill child. So, what is the fifth vital sign then? Students can tell me up. So you have 4 vital signs. What is the fifth one? Because I'm saying this is the sixth vital sign. Saturations. Yep. Oxygen saturation is the fifth vital sign we're considering now. So DKA is characterized by a biochemical triad of hyperglycemia, where you have blood sugar of more than 200 milligrams and a venous pH of less than 7.3, or where you don't have VBG or ABG facility available. If the bicarb levels are less than 15 and there is a ketonemia, the beta hydroxybutirates are more than 3 millimoles per liter, or moderate to large ketonuria is there. And you classify the severity as severe is less than pH of less than 7.1 and bicarb of less than 5, or moderate is 7.1 to 7.2 and mild is 7.2 to 7.3. So what are the risk factors for DKA? So any child who is newly diagnosed with diabetes, younger age, delayed diagnosis, lower socioeconomic status, and also country where the incidence of insulin-dependent diabetes is less. And in non-diabetics, you have a long list. You have sometimes there can be insulin omission, poor metabolic control, previous episodes of DKA, acute GE with persistent vomiting and hydration not improving, and psychiatric disorders, including eating disorders, and challenging social family circumstances, peripubertal and adolescent girls, and those with limited access to medical services and insulin pump therapy failure. So what are the goals of therapy? You have to correct dehydration and electrolyte deficits. You have to correct acidosis and reverse ketosis, and gradually restore the hyperosmolality and blood glucose concentration to near normal, and keep monitoring for complications of DKA and its treatment, and identify and treat any precipitating event. So this is the algorithm. So once you have clinical history where you have polyuria, polydipsia, nocturia, anuresis, either weight loss, nausea, vomiting, abdominal pain, weakness, and fatigue, and there is a confusion or decreased level of consciousness, and you have dehydration and acidotic breathing and ketonic smell to odor. And then if you fulfill the biochemical features, so once you confirm that this is DKA, now whether a shock is present or not. If you have shock, you have to resuscitate the child as any other shock child. You have to give first 10 to 20 ml per kilo of normal saline, reassess. Once the shock is resolved, then only move to the next thing. If the child is not in shock, but the dehydration you assume to be 5 to 10%, and then you carry on with the IV fluid therapy. So initial fluid therapy can be either normal saline or half normal saline, or even RL sometimes. So there is a large PECAN trial which has got this is an RCT where they have shown that using either normal saline or half normal saline and correcting it either over 24 hours or 48 hours has not created any great deal of impact in terms of CNS complications. So you have to keep going on with the IV fluids, calculate the fluid requirement for the dehydration, and start the maintenance therapy. Once urine output is established, you also add potassium to the fluid. Keep monitoring for ECG, keep monitoring the other vital parameters, which will come in the next slide. And once first hour of fluid therapy is gone, then only start insulin. So there is no insulin bolus, and the insulin needs to be started only after the first hour of IV fluid therapy. So what are the things which you are going to monitor is hourly blood glucose, hourly fluid input and output, the neurological status, at least hourly we need to see for GCS, pupils, and electrolytes initially after 2 hours, and then depending on the course of the disease, you have to take the call, and keep monitoring the ECG for any T wave changes. So whenever the blood glucose, you have to make sure that hourly blood glucose fall is between 2 to 5 millimoles or 35 to 90 milligrams per deciliter. If it is falling too rapidly, you have to add dextrose to the IV fluids. And if it is falling below 300, or some units will have the range as 250. If it is falling below 250, you have to add glucose, dextrose in the IV fluid. If acidosis is not improving, you have to go back, you have to see whether there is ongoing overt losses, whether the rehydration is not complete, or is there any problem with regards to insulin therapy. If the preparation is good, if the equipment failure, insulin pump is not working, or the IV line is extravasated. So you have to just go back and see, and also rule out infection, rule out sepsis. So that is also something which can lead to continued acidosis. So the IV therapy needs to be continued, and as I already told, if once you have started the therapy and if there is no increase in the serum sodium, because remember, when you have such a severe decay, there will be pseudohyponatremia. So once the blood glucose is improving, then is falling, then you have to see the rise of serum sodium. And if that's not happening, and if you are using say 0.45 normal saline, then you'll have to increase the sodium content of your IV fluid. So what are the warning signs when you see that there is neurological deterioration? So any sudden onset or new onset headache, which is not which is refractory to your paracetamol, or any change in the mental status, confusion, altered behavior, or any incontinence, and then the heart rate is slowing, the blood pressure is rising, that tells us that the child is now going into cerebral edema, and we have to act accordingly. We have to start mannitol or 3% saline, keep the child's head elevated by 30 degrees, and also have the head in midline, and keep things ready for if you feel that airway is compromised or there's impending respiratory failure, you have to intubate the child. So as we've already discussed, the choice of the fluids, initial bolus will be normal saline, but afterwards you can either choose normal saline or half normal saline, or sometimes even RL, and deficit to be calculated as 5 to 10%, and it needs to be replaced over 24 to 48 hours. And once your RBS falls below 250 to 300, you have to add dextrose in the fluid. You can use up to from 5% to 12.5% in a peripheral IV line. And potassium also needs to be added to the fluids. And as we have already discussed, sodium concentration needs to be increased if the sodium is not rising with fall in the blood glucose. So with regards to insulin, bolus is not recommended anymore, and start the insulin infusion only after 1 hour of starting the initial fluid therapy, replacement therapy. So be very clear about how you want to dilute the insulin to your staff, so that there is no confusion and everybody is on the same page. So simple formula is take 1 ml of regular IV insulin, which is 40 units, and dilute it in total 40 ml of normal saline, which gives you 1 ml is equal to 1 unit. And you start it with either 0.05 to 0.1 unit per kilo per hour. Again, an RCT has shown that 0.5 unit per kilo per hour of insulin as an initial regime is non-inferior to 0.1 unit per kilo per hour in terms of resolution of acidosis. But also 0.1 unit per kilo per hour is also not harmful. So you can have that range depending on you'll have to individualize that decision. So for less severe DKAs, usually 0.05 unit per kilo per hour is usually sufficient. And if the clinical and lab parameters of DKA do not improve, if your child is not improving, your acidosis is persisting, you have to keep reassessing the patient. You have to review your insulin therapy. You have to consider other possible causes of impaired response to insulin, which is infection, errors in insulin preparation, or the route of administration. So another thing is, because these kids, if you look at the pathophysiology, the child who has presented to DKA has been insulin deficient for quite some time, and thereby polyuria, polydipsia has led to a lot of fluid loss, as well as many electrolytes are lost. So they are severely depleted in terms of electrolytes, especially the potassium. So even though they are potassium, they are severely depleted. Many times you may not see a hypokalemia. Mostly you will see either normal potassium or a little on the higher side potassium. So whenever you see hypokalemia, you have to understand that once you start insulin and once you start improving the acidosis resolves, the potassium levels will further fall down. And if the child is already hypokalemic to begin with, you will have a severe hypokalemia, which is very detrimental to a patient. So whenever you have hypokalemia on admission, you have to make sure that you address that before you start insulin therapy. So you have to use the potassium at a maximum dose of 0.5 milliequivalents per kilo per hour, and you correct the potassium, you get it to a normal level, and then you initiate the insulin therapy. So once in children who are having potassium on the higher range, you have to start potassium once it is documented. And you can also use potassium phosphate and potassium chloride. How many of you have used potassium phosphate here? Raise your hand. Not using? Yeah. Okay. So you have to remember, POTFOS is available. You can use it, especially when you are having something like, as you treat the child of a DKA, hyperchloremic metabolic acidosis is something which is known. So once the hyperchloremia is there, if you are using KCl, that will further add to the chloride load. So if you want to reduce that, you have to use POTFOS. So you have to only remember that the concentration is different. 1 ml of POTFOS gives 4.4 milliequivalents of potassium and 3 milliequivalents of phosphorus. So you have to remember that in terms of KCl, it is just 1 ml is equal to 2 milliequivalents. So it is almost 2.2 times more. So you have to bear that in mind. Apart from that, you can use that. And you can use half of them both. Like it is compatible with POTChlor also, potassium chloride as well. So whenever the hypokalemia is refractory, as in any other case, you have to consider that it may be hypomagnesemia, and you can give magnesium supplement so that the hypokalemia gets resolved. So whenever there is a severe hyperkalemia, which sometimes you may get if the pH is too low, less than 6.9, or if the child is in established ARF, so then that is one of the rare indication of using bicarb. Even though we are seeing such a severe acidosis, we never use bicarb in DKA. So the bicarb in DKA only when you have severe hyperkalemia with ECG changes. There you have to use bicarb so as to prevent arrhythmias. So pseudohyponatremia usually improves with fall in blood glucose, and hyperchloremic acidosis is something which can occur, and you have to reduce the chloride content of fluids. You use either RL or 0.45 normal saline, and use instead of KCl, use POTFOS. Hypophosphatemia also can be a problem, rarely, and it becomes symptomatic when the child is having the phosphorus levels less than 1 milligrams per deciliter. Again, here you can use POTFOS, but whenever you are using potassium phosphate, as the potassium supplement or phosphorus supplement, you have to make sure that you are monitoring calcium as well, and you are supplementing calcium if the calcium is low to begin with. So what do you monitor? You monitor for vital parameters and also for the ECG that needs to be continuously monitored. And you look for any T wave changes, any rhythm abnormalities, and also how the tachycardia is settling down or not, and how is the blood pressure. And neurological assessment with regards to overall neurological status, GCS, pupils, and fluid input and output needs to be meticulously monitored hourly, and capillary blood glucose as well. And labs, depending on the child's clinical course, initially it will be a little more frequently, 2 hourly or 3 hourly or 4 hourly, and then depending on the child's clinical course, it can be tailor-made. So what are the complications? One of the most feared complications is cerebral edema. It can either be because of the disease process itself, or as we are dealing with a child who has been hyperglycemic for quite many days, and the body has started adjusting to that hyperglycemic milieu, and there are a lot of osmoles generated. So as we treat the child, there can be a rapid fluid shift. So even though our aim is to grow very gradually in terms of resolution of acidosis as well as hyperglycemia, you can still have this deterioration in the neurological condition of the child. So you have to be constantly on the lookout, and that's why you have to go for hourly monitoring of the status. So, and then hypokalemia, as we have discussed, once the acidosis is resolving and you are giving insulin, both of them are basically treatment of hyperkalemia. So hypokalemia can occur, hyperchloremic acidosis as we have discussed, and hypoglycemia, again, you have to either, when you have got hypoglycemia, you have to stop insulin infusion for a while, and you have to give more dextrose and get the sugar levels back to normal, and then restart your insulin therapy if the child is still acidotic. And inadequate rehydration, again, you have to calculate the fluids properly and stick to your plan and carry on with it. And if there are overt losses, you have to go ahead and get that fluid replenished. So cerebral edema, we'll talk briefly about. New onset headache, change in neurological status in terms of confusion, irrelevant talk, drowsiness, or irritability, and incontinence. These are the main clinical symptoms and signs where you should think about cerebral edema. There can be some specific neurological signs like papilledema or cranial nerve pulses, especially third, sixth, or fourth nerve, and recurrence of vomiting, and inappropriate slowing of heart rate and rising blood pressure. And if there is a rapidly rising serum sodium, which is because of diabetes insipidus, you have to assume that this is because of the raised acidity. So how do you treat it? As Dr. Parag already discussed, by giving hypertonic saline or mannitol, and you have to initiate the therapy on suspicion itself. You don't have to diagnose cerebral edema by getting a neuroimaging. You have to initiate it because this is an emergency. You have to start the therapy itself, and then once the child is stable enough, then you can go ahead with the neuroimaging. Head end elevation by 30 degrees, and avoid overhydration as well as avoid hypotension. Overhydration will lead to further increase in the venous pressure and cerebral edema, and hypotension will lead to decrease in the cerebral perfusion. So you have to avoid that, and if there is impending respiratory failure or the child is not able to maintain his airway, you have to go ahead and intubate the child. All right, so I think we are in time. So if there are any questions, take questions. Thank you.
So what Dr. Chetan was saying about 0.05 units is only one RCT, I think, from PGI.
Yeah.
So there is a lot of controversy in that, and we have seen sometimes decay taking very long time to recover. So as he said, in mild decay, you may try that, but in severe decay, if you are starting with 0.05, wait for 8 to 12 hours, and if you think the response is slow, go to 1.1 units. All right, so the next talk is by Dr. Nitin Chawla. He's going to talk on common office emergencies.
Good afternoon, everyone. I'd like to thank IAPTCB and Team Rainbow to invite me and give me this opportunity to talk to you about common pediatric office emergencies. We have been in room with a lot of emergencies which are being settled in ED and shifted to ICU. Now I'm going to take you to OPD and try to keep it you in OPD, and we'll try to be in OPD. If needed, we'll go to ER. So baby, 18-month-old male, which he complains of unable to move his left wrist, crying intermittently when elbow is moved. Any PG? Okay, let's take it further. He's not using his left arm or lateral left forearm. He's describing it as feeling very hurty, and there's no obvious deformation of the elbow or wrist. There is inconsistent reaction to palpation and when you're trying to move his wrist or elbow. Now anyone? Pulled elbow, yes. Also known as nursemaid elbow. Long time back when nursemaid were the caregivers, the caretakers, that was a time when they used to pull the child either from preventing them from a fall or want to pull them to do something, and that's the time when this injury was identified. There is a subluxation or a partial dislocation of the radial head. Annular ligament, technically it surrounds the radial head, and radial head slips, and this annular ligament get trapped between the radiohumeral joint. This sudden pulling motion in axial traction with the elbow extended is the mechanism behind it. Child will present with symptom that he is unwilling to use his arm. The arm is usually on the side, pronated with slight elbow flexion. There will be resistance and pain whenever there is a movement at elbow or forearm. Do we need an X-ray for this? Clinically, it's a clinical diagnosis. At first instance, there is no need of an X-ray, and you can treat by doing a simple maneuver, which we are going to talk soon. Still, there are certain circumstances when you will be needing an X-ray. If this child, along with the present circumstances, there is an injury or deformity or swelling or bruising at the elbow, even after taking doing the maneuver, there is no improvement and the pain and condition of the child is not improving. That is another indication where imaging is recommended. So what is a maneuver for reduction? Before we go for maneuver, has anybody ever tried this maneuver? Yes. Were you successful? Always. So this is the confidence which a clinician, once they feel that click, they will always feel the click. So child is having his arm on the side pronation. So what you have to do is pull, pronate, and flex. Here, if we see, it clearly defines apply pressure over the radial head while you're pulling axially, fully pronate the forearm and then flex the elbow. Second, apply pressure, supinate the arm and flex the elbow. While you are doing this, there is a click which you're going to hear. I'll come to you, sir, for sharing your experience. Yeah. So supinate and flex or pronate and flex, these are the art where you will bring radial head back into the annular ligament and this will be relieved. Other case, OPD room scream. A 6-year-old boy rushed in by the parents, screaming, agitated, holding his crouch area. When you're trying to open his leg, he's just shouting a lot. Anyone? Okay. Zippies. Zipper-related penile injuries. Their incidence are very low, 0.5% worldwide in all emergency room pediatric visits. There is a compression. Anyone has ever seen? Some have, some haven't even tried to. Compression and entrapment, bleeding, swelling, pain, contusions, bruising, and other type of tissue injury has been reported. The general rule is longer the tissue is trapped, the greater is the damage. Skin or foreskin or scrotum are the two places which get stuck. The two sides are either between the teeth of the zipper or within the sliding part of the zipper. Now, this resolution on a maneuver depends on the site which is involved. Management has 4 prongs: analgesia and sedation, mandatory. Local anesthesia, maybe. Extrication from the zipper is what we want. And if we are not successful, then we should have a anticipation and OT ready to get things resolved. For sedation, ketamine and intranasal fentanyl can be utilized. We should be ready to support airways if at all we are planning to go for sedation. Anesthesia, lidocaine, specifically just note that it should be without adrenaline and it should be infiltrated to facilitate removal. Now, the choice is the pain for putting in an injection versus confidence on taking care of the problem is the decision which a clinician should take, whether to put that local or whether you go ahead with the procedure, which we are going to talk soon. EMLA, it is good, but it takes 45 minutes. And while we think 45 minutes, lot of pain, the child is with holding his crouch area, doesn't seem so logical. So EMLA is there on the list, but not usually being given or applied. So here are two. There's the skin is between the zippers. Here we have two places where we can cut, above or below the site of entrapment, and then gently we start opening the zipper. This will release the clasped skin and we are able to remove if the skin is between the zippers. Easy. Tough part yet to come. First, let us understand this zipper. It is an anterior plate, it is a posterior plate, and is a median bar which holds it. The art is to make these two plates go away, and how we do it? We do it by cutting the median plate. That is one of the way which has been mentioned. Success rate is 62%, failure rate is around 30%. But we have to understand that there could be pain involved in doing this procedure, and usual hospitals, they have bone cutters available which are bulky, big. And if we talk about zip of a 6-year-old, the zip size is very less. The tip of the bone cutter itself is around 3 times bigger than the zip size. So we should have a long prong cutting wire cutters in our ED if we think we are keeping it ready for anything, any untoward OPD like this. So our aim is to cut the median plate with the bone cutter so that anterior and posterior flap of the zip are released and we can relieve the entrap skin. This is the long wired cutter which we all must have seen while people are coming to take care of the electrical fittings. We have seen there are good quality grade available. Second is you can put a flat head screwdriver between the two plates and rotate it 90%. So when you do that, the two opposed plate with support from the upper holder will get removed. Another problem, lot of pain, because if skin is there between the two plates, you are exerting pressure and thinking that at some point the plate will break, then you are actually putting in a lot of pressure to break the plate, and at the same time there will be a lot of pain. And I am seeing people thinking about it, and yes, it is traumatic and it is painful as well. Mineral oil, 94% success rate. Applied for 15 minutes, lubrication, it will swirl the place. You can go oppose the zip to be pulled down and penile skin to be pulled up. Success rate is 94%. Patience, time, and availability of mineral oil. One thing that should not be done, bottom line, do not attempt painful manipulation. Always involve anesthesia or adequate analgesia, because this painful experience is always counterproductive and uncomfortable for the patient. Okay, official in emergency. I've tried to keep the heading catchy so that at least we will have some more interest. We are towards the end of the session. Yes, sir. The 2006 report in IAP says that you hold the zip from up and you press both the lateral end. The 2006 report. Yes, sir. Yeah. Yes. Between the two interdigitation, you can cut it, right? Agreed, sir. Yeah.
Kind of a stitch or a plate that holds the lower edge of the zip.
You can, if one of the portion of the zipper is open, you can actually pull it apart. This is what you're saying. That is what I tried to tell in the beginning. The easier one is when the skin is between the zipper plates. The difficult one is when it is in the sliding apparatus. That is the difficult part, painful one. Don't try to unzip if you don't have mineral oil. Otherwise, keep it easy on you. So official in emergency is a hospital, and this is one circumstance which has been recognized recognized in various places in the world, and this need to be addressed, and all of us should be ready, because this we are also going to face in some point of time in upcoming months. A hospital staff got vaccinated for COVID-19, and post-vaccination she presented to OPD with complaints of rashes, difficulty in breathing, and feeling dizzy. Anyone? What is it?
Duration? How long after that?
Let us take 15 minutes, because I want the scenario to be considered: rash, difficulty in breathing, and dizzy. Anaphylaxis, anaphylactic shock, we are worried कि हो तो नहीं गया, rash तो नहीं है, problem तो नहीं आ गया. It happens. Even in India, COVID-19 vaccination, pandemic approach, everything is fine, but are we ready to handle it? Are our hospital, our clinics primed to take care of it? And we have female staffs, pregnant female staffs, male staff, elderly male staff working with us. So are we ready to take care of them when they really need it? This is it. Let us see. So Resuscitation Council of UK in 2021 have given this guideline. It's a one-page flyer, can be printed, can be placed in your OPDs, in your EDs. One drug need to be with you: ADR, adrenaline, simple formula, less than 6 months. So I would like all of you to focus on the bottom. The second IM, adrenaline, easily can be given. Child less than 6 months, 0.15 ml. That dose, 0.1 to 0.15 ml. Children 6 months to 6 years, 0.15 ml. 6 years to 12 years, 0.3 ml. Above 12 years, 0.5 ml. We need to have such kind of algorithm protocols stuck to our walls so that we don't have to worry. Now, let us go point by point. Airway, breathing, circulation, disability, exposure, primary assessment. Any patient coming, we have to assess. This is the person of any category, of any age, who will need ADR at the end if symptoms are not resolving. Now, here we have to look whether there is a sudden onset of airway or breathing or circulation problem. In our case, yes, patient was feeling breathing difficulty and dizzy. So we have to evaluate the vitals. If heart rate are going beyond the physiological rates and BP is not being managed, or breathing difficulty with saturation drop of less than 94 is happening, probability of having compromised airway will be there. Call for help if you are in office setting and you don't have experience in handling such kind of patients. Always call for help. Anticipation of problem is the half battle won. So anticipate. Intramuscular adrenaline is the one drug which is a take home here, which should be with you. Should be with you because injections are very easy to be given and can be handled anyway. So life-threatening problem which we can see in such kind of patients is airway having swollen airway, hoarseness of voice which we will feel, and stridor. Breathing difficulty, the patient of any age will have rapid breathing, they will be wheezing, saturations if we can monitor will be less than 94. Circulation, pale, clammy, low blood pressure, fainting or drowsy. These are the parameters which need to be addressed when we are taking care of such patient. If we are giving ADR and if after 2 doses also the patient is not responding, this is the time when we should considering start of IV ADR in a resource in the setup which can take care of such patients, preferably in a pediatric intensive care unit. Now, how does ADR work in anaphylaxis? Okay, so ADR works first by mast cell stabilization, second by decreasing the vasoconstriction and edema, third by improving beta agonist action by causing bronchodilation, fourth by beta agonist action on the heart by improving contractility. So this drug will give you all fronts covered and will make your life easier if you're dealing with any kind of this problem. Save her smile. 10-year-old girl came to your OPD with history of injury to face due to fall while dancing, and a median incision is in her hand. Can we save her smile? Yes. So dentoalveolar trauma, it includes injury caused by an external impact to the dentition and its surrounding structures. The peak incidence is 7 to 11 years, most commonly in male. Falls are most common causes, with cycling accidents second, then full contact sports third. Maxillary central incisors are the most common, and maxillary lateral incisors are second most common. Periodontal ligament is one structure which we all should know, that this is the most important ligament which takes care of entire process of either reimplantation or wastage of the tooth. is the ligament which connects from cementum, which is part of the tooth, to the bone, to mandible or maxilla. Periodontal ligament can tear, and this allowing partial or total displacement of the tooth from the socket, and there will be neurovascular disruption as well as pulp necrosis if not handled well. Viable PDL will give after avulsion is integral to long-term prognosis. Immediate reimplantation will allow PDL to reform the connection between the tooth and alveolus. 90 minutes, वो 70 minutes, ये 90 minutes. 90 minutes is the most important time. If things are not being taken, all steps are not being taken care, then there is a high possibility that even after reimplantation, you will lose the tooth. There are 5 steps what a pediatrician can do. Before these 5 steps, I like to add, always anticipate and always make a call to your known dentist where you're going to send this child. Okay? Keep calm. Make sure that this is a adult tooth. It is not a primary tooth. They are not, if we are going to put a second primary tooth into the socket, then we are actually going to harm the permanent tooth. So you don't want to keep the tooth which is going to be fall anyway in upcoming years. You have to take the tooth from the white of the tooth, not from the sharp end, not from the root, because that is the place where there is periodontal ligament and membranes. If they get affected, there will be no further take by the skin because there will be affection over there. If the tooth is dirty, we can use cold saline, we can use milk, we can use cold running water as well. Best way for transportation is to reimplant from the tooth from where it has been fallen. There is always a groove. So you try to find that and put it in. Give a handkerchief to the person to put it in the mouth and bite it. That will splint, and send them to the dentist. If this is not possible, if you're scared, if blood is too much and you're worried, every aspect taken care, you can ask the person either to take it in a bowl, in a glass of milk, which is unlikely because when this type of injury will happen, kahan se aayega tooth? Difficult. So ask them to keep it between the gum and the jaw. This groove is the right place. Saliva, it will do everything for the tooth. So this will be the safe medium for transportation. Okay. How to care for replanted tooth? Maintain good oral hygiene. For smaller kids, chlorhexidine mouthwash with Q-tip is ideal. For older children, they should rinse their mouth 1 to 2 weeks. If a child is a compulsive thumb sucker, then he or she should refrain from such, because this extra force will be dislodging the teeth in near future. Always ensure that your patients and the parents who are coming and the children are into contact sports or any kind of training, they should use mouth guards. Good quality guards will save their smile anyway. Candy blues. So 2-year-old brought to OPD for vaccination. Mother gave candy to the crying child and suddenly child is turning blue and is unable to breathe. So what to do? Anyone? How many of you have done PALS? Okay. Should we hit their back? Is it the entire shoulder length? Is it on the blade? Which? Between the blades. Okay, let us see. So let us go on the right side of the picture. But the bigger child, 2-year-old, back blows to clear the airway. First of all, in such situation, we should remember whether the child is able to cough or not able to cough. If they're able to cough, encourage them to cough. The positive pressure from deep inside will be able to take care of. The cough is a protective reflex. It is going to take care of this obstruction. But if it is already turning blue, then we have to intervene immediately. We have to give pat between the shoulder blades. At the same time, if child is choking, we have to give a Heimlich. We can give a Heimlich maneuver. So make a fist, put it over just under the sternum with your second hand, encircle the person, gulp, upward and inward. This is the portion where you are going to give the thrust. So after back blows, give 5 blows to middle of the child's back with heel of your hand, with the child sitting, kneeling or lying. If obstruction persists, go behind the child and pass your arm around child's body. Form a fist with one hand immediately below child's sternum. Place other hand over the fist and pull upward into the abdomen. Repeat this Heimlich maneuver 5 times. If the obstruction persists, check child's mouth for any obstruction that can be removed. If necessary, repeat this sequence with back blows. Similarly, if this happens with an infant, lay infant on your arm or thigh in a head down position. Give 5 blows to the middle of infant's back with heel of the hand. If obstruction persists, turn the infant over and give 5 chest thrusts with 2 fingers on the lower half of the sternum. If still obstruction persists, check infant's mouth for any obstruction that can be removed. If necessary, repeat sequence with back slaps. Only science behind it is to increase the intrathoracic pressure. आगे पीछे करके obstruction को remove करना है. Now, if patient is not able to respond, then what? Back to BLS, CPR. If they're not responding, not breathing, CPR. No confusion in that, because life need to be saved. Things need to be done in the right way. That's the basis of algorithm-based approach. With this, I would like to conclude. These were my references, and thanks for the patience.
Sure. Just a couple of thoughts, especially because, just sharing some thoughts. I'm part of the state task force for COVID-19 vaccination, and we recently had a AEFI committee meeting. And after giving the COVID vaccine to more than 1 lakh health functionaries across the state of Telangana, we reviewed 748 cases of AEFI. And one of the important take-home message from that day-long committee meeting, where we reviewed all the 748 and tried to understand how do we make this vaccine more safe, more so as we get into the general public. Most of the vaccine sites have been hospitals, and this is going to be a prerogative, especially from tomorrow when we start giving the vaccine to non-health functionaries. Very important that we continue to do this only in hospital premises, only in places where you can manage AEFI. If you cannot manage AEFI, don't give the vaccine there. The second take-home message, the incidence what we have seen is close to around 10 per million, but that also is a big number. 10 is actually a concerning number, and we need to be prepared as well. Two key things, especially for those who are likely to be involved in the vaccination part, kindly check the expiry date of adrenaline. It's a very short expiry stuff. Please look at the expiry date and please mark it on the AEFI kit whenever you put it. And make sure, let's say you're starting in March, make sure you have it at least for 1 or 2 months and indent new stock. Second, and this is probably the biggest difference, do not, and I strongly say, do not use insulin syringes to give adrenaline. The insulin syringe will not give you IM. It will only give you subcutaneous. Check the AEFI kit. You most likely will have insulin syringes in it. And all those cases where we had severe anaphylaxis, we ended up giving adrenaline subcutaneous because they had the subcutaneous syringe. So make sure you have a proper IM syringe in adults, because as from tomorrow when you start it, it's going to be adults who are non-health. It will be 0.5 ml. Be ready with it. And all ANMs are now authorized to give adrenaline. And the last point, don't be scared of giving adrenaline. Don't worry about what will happen next. Your first intent is to save. Do not refer without a pre-referral dose of adrenaline. Give it and only then refer. We've had deaths due to COVID vaccination, and we try to understand how will we be able to save them more. And these are some key take-home messages. Thank you. Yes, sir.
Which of the two vaccines have got the higher incidence?
Yeah, we didn't do that kind of an analysis because the database is not strong enough. Because as you have seen, Covishield was started much early, and then Covaxin came in a bit later. So it's unfair to compare them on that front. But on an official note, we strongly vouch, whichever is the vaccine, both of them are safe. Despite all this AEFI, despite all this, both of them are safe, efficacious, and much recommended. When your time comes, please take it. That is the bottom line. And strengthening AEFI is only to ensure that our systems are strong enough so that you can handle it. The more you run away from AEFIs and run away from anaphylaxis, the more likely that you're causing harm to someone else in the process of time. So it's all, this is what we call as strengthening the health systems. Thank you. Over to you. Yes. Yes. All hospitalized, or anyone who comes, or I would say referred anaphylaxis, require admission. And please consider even the cutaneous symptoms. It's not necessary that it's always only respiratory that will suddenly worsen. Cutaneous symptoms, please continue to monitor them. They might eventually have respiratory symptoms, and by that time they would have gone home, and it becomes a bigger task to monitor them and then come back. So anyone with reported anaphylaxis, ensure they are monitored and keep them in the hospital if they have come from one center, especially from a PHC or a local CHC. Keep them for observation for 24 hours. Only after vitals stabilize, then send them back. Adrenaline is the same. It's just that the focus is on the syringe. Do not use insulin syringe, and be confident to use it. Nothing will happen. You're actually trying to save someone. So don't bother about the heart. Don't bother about potassiums. It is safe, and by government it is mandated that you give it before referring. Do not leave adrenaline for the referral hospital. They will do other airway maneuvers. But adrenaline is your responsibility in case you have given the vaccine at your place. Yeah. Over to you, Dr. Farhan, for the panel discussion. Yes.
So now we are at the final session, which is the panel discussion on decisions about choosing the right antibiotic. So we have tried to keep it simple and more useful for our practicing pediatricians, and basic intensive care, not very advanced, not very complicated antibiotics. So my first question is to Dr. Nitin. This is a 3-month-old child who is admitted with features of meningitis, and investigations support the same. Child was started on IV antibiotics based upon the culture reports of the CSF. Ceftriaxone vancomycin was given for 7 days. Now the child is asymptomatic. Parents want to go Lama, or they want to go to some other hospital. They just don't want to continue with you now due to financial constraints. What best can you do now? Stop the antibiotic because child is asymptomatic, start on oral antibiotics, or continue IV antibiotics on home, like OPD basis, ask them to come morning, evening for antibiotics, or any other better option?
In this scenario, I would like to go for continuation of IV antibiotic at home, because we should follow the late guidelines by IDSA, and when we are talking about gram-negative infection leading to meningitis, ceftriaxone for 14 days, and if conditions are deteriorating, can extend up to 21 days with the informed consult by a preferably pediatric infection specialist if we have an organism in hand. If we have a 3-month-old or a child who is clinically meningitis, but we are not able to get any culture positive, but we have that surety that this child is having meningitis and TSF is suggestive of meningitis, but culture is not positive. Here also, the cefotaxime for 14 days. If we are dealing with a meningococcal infection, then mandatory 7 days of cefotaxime. Listeria is one organism where the dose of antibiotic should be recommended for 21 days. And we can have an add-on of amoxicillin as well. In certain circumstances, 7 days of gentamicin can also be considered. These IV antibiotics in a child of meningitis, in counseling in such patients, this point of prolonged IV route to be utilized should be told to the parents and should be followed.
Very good. So basically there are two things here. First is, don't compromise on duration of antibiotics in meningitis, because you will end up having a partially treated meningitis, which can complicate into a subdural empyema or a ventriculitis. It can become a big nightmare later on. First thing. And second thing is, you need to counsel the family. Very, very important. Once you diagnose meningitis first day, that day itself, the parents need to understand the magnitude of the problem, expected line of treatment and duration and everything. They should be very clear, rather than after 7 days they coming back. You have to explain to them that the child will become almost normal after 5-6 days, but that doesn't mean that your child is fine and we need to give this antibiotic for so much duration. Then things are very important, clear usually. If you don't inform all that, then this kind of controversies come. Third thing is on antibiotics on OPD basis, generally we avoid. in Indian circumstances. Foreign countries, that's a different thing. But in Indian circumstances, usually ERs are busy and infection control and those practices may not be very well established in emergency room situations. And then the child coming every day, morning, evening, for antibiotics in the ER where the nurses may not be handling the cannula properly, how they give injections, so many things are there. And if they go to another hospital, what what kind of brand again of the antibiotic is being given. There are so many things which come into equation. If you are very confident that the family is good, your ER is very good, nurses are well trained, they can manage, then I think we can continue. Otherwise, always better to keep inpatient. You can give them some discount or something, or keep them inpatient and continue, or send them to another hospital where they can be kept inpatient and continued antibiotic there. Right. So the next question is to Dr. Chetan. 2-year-old child who came with fever, irritability, red bulging eardrum, diagnosis of acute otitis media, started on amoxicillin 50 mg per kg per day, proper dose. After 2 days, the child got diarrhea. Parents were anxious, hence the physician reduced the dose to half. And after 5 days, still the fever is persisting, and there is a confusion now. What was the mistake, and what could have been done?
So acute otitis media, always you have to make sure that antibiotic which you are using at appropriate. So 50 to 80 mg, 90 mg per kg per day is the dose needed for amoxicillin or amoxicillinic acid. And antibiotic associated diarrhea is yes the problem, but we have to just keep counseling the family. The child is active, training, is having good urine output. They just have to bear the side effects. We can use zinc and ORS and dietary modification, but you cannot come down on the dosage because that will again lead to
So giving in the inadequate dose is also not a good practice basically. So continue same dose, or you change the antibiotic to another which will be less likely to cause or aggravate diarrhea, but don't compromise on the dose. So the first scenario was about duration, appropriate duration, and the second scenario was about appropriate dosing of the antibiotics. Now, next question is to Dr. Anupama. 11-month-old child with sudden onset fever of up to 101 degrees, and child is having vomiting previous day and has started with loose watery stools today. And the doctor started ofloxacin nonidazole combination. Will you continue this antibiotic as there is fever, or will you stop as you feel that it is viral? What is the correct approach?
in this case also, if you have started on amoxicillin, yeah, all hemoglobin values are still susceptible to pain and oxygen. There is no need for amoxicillin. Only finding the amoxicillin syrup sometimes becomes a problem.
That's a problem.
You can't have so much of too many medical stuff.
Yes.
Many times that's the reason ultimately the child gets amoxicillin.
Yes.
Another problem is the child is more than 2 years. Most of the time it is self-limiting. Try not to give antibiotics for 48 hours. Observe the child worsening symptoms earlier than you can. So after 2 years, it is watch and give the antibiotic.
Yeah.
If it is less than 2 years child, suppose
Still,
the
yeah.
infection is there, bilateral low is there, then you can use the antibiotic. Preferably
But it's very difficult to get plain amoxicillin.
from here, if you tell amoxicillin, people always say it is always a problem. Diarrhea will be there with amoxicillin, and they will stop the antibiotic.
But it's difficult to get amoxicillin.
Amoxicillin
Yeah, plain amoxicillin, yeah. And if you don't know the organism, if you're not sure about pneumococci, then that's a problem.
empirically also, IAPTCB also says that 80% of the time it is amoxicillin, it is appropriate antibiotic for the human. It is very difficult to do. It's only the empirical antibiotic.
True.
Most of the time it is viral diarrhea, especially in winter season. So initial antibiotic is not required when we see a child with acute gastroenteritis. Yes, we would consider antibiotic if there is high grade fever or we see blood in the stool, affecting enterocolitis, or the child looks toxic. Then yes, we would consider an antibiotic. Ofloxacin, by
Better not to give antibiotic at all because of watery. Use it only when there's a plenty of pus cells, high grade fever, inflammatory markers are elevated, only those cases. Yes. Parag is not there. This is a scenario about a 9-month, 9 kg child weighing previously healthy boy presented to the emergency department with runny nose for 2 days. Mother noticed that he is breathing at a rate of 60 to 70 breaths per minute with mild chest and drawings and not feeding well. Hemodynamics are normal, saturations 96% at room air, hyperinflated lungs. Investigations unremarkable in the sense WBC counts are normal, platelets are normal, inflammatory markers are not elevated, and the diagnosis provisionally made is looking like a bronchiolitis. So you decide to admit this patient now in your ICU and start him on humidified oxygen. What antibiotics will you use?
Presentation is like bronchiolitis. It has to be viral illness. I would probably not start any antibiotics and keep it. Meanwhile, we will have the investigation and see how it go on. More than antibiotics, respiratory support that we have to look at.
Okay. So we were all expecting this answer. My next question is the decision of not starting antibiotic in a child with bronchiolitis is just on a paper? Do we actually do in our practice? Do we actually don't start any antibiotic? And why? Why it is important? Not why? When will we get the confidence of not starting antibiotic of a child who's 9 months old, admitted in the ICU, child is on HFNC, child has an IV fluid going on, and no antibiotics? So when we get that confidence? How do we get that confidence?
By attending discussion. Understanding the art of medicine.
Correct.
Experiencing it.
Investigations are reflecting no infection. CRP is negative. WBC counts are normal.
It's partly true that most of them
Cultures are also sterile.
get on antibiotics, but yeah, some of them they do. If they come in a really bad state with a lot of X-ray changes and all those things, some of them cure like at least the antibiotics will cure the typical microorganism. But yeah, ideally they should not be. But it's not in 100% as it is in the practice.
Mycoplasma.
Yeah. That's what we try to cover.
It's not the misleading state.
Yeah. Like,
So very important thing about bronchiolitis, everybody knows 70% of the infection what we are seeing are viral. And then there is a borderline where there is a viral and bacterial. But reasonably we can rule them out with laboratory investigation. Now another thing we have to understand is once the patient is coming to us, as a referral hospital you can say, or at some mediocre center, the patient is sent by some of the physician. They are not sending you for initiation of something in the form of not changing of an antibiotics or upscaling the antibiotics, because they are in the deteriorating phase of the disease where you require good respiratory support, oxygen, nebulization rather than upgrading the antibiotics. Third thing is it's very well known, and you will see a lot of research related to giving azithromycin for a bronchiolitis. There is no role. There is definitely no role. Atypical things. Less than 1 year, more than 10 years, when you are seeing it properly, when you feel there is a possibility of atypical pneumonia in the form of high CRP, then you can think about adding it. And fourth thing, very, very important is it's not only that CRP is high in a bacterial infection. We see a lot of, because if you see before COVID started, we saw a lot of adenoviruses. And you can have a CRP of 100, 120 also. So it's not only actually you think about adding something antibiotic. It might give a false sense of satisfaction that we are giving something, but keeping all, let it be, you are thinking a worst case scenario, you started antibiotics. That's fine, it's okay. At admission, you started something, but be vigilant to stop that end of 24 hours so that you are not actually increasing the duration of antibiotics.
My expectation for this was actually is the confidence of not starting antibiotic in any unit comes from your own infection control practices. Be it your labor room, or be it ICU. If your infection control practices are robust, strong, you are very confident that your nurses are well trained, there is a good adherence to hand hygiene, and sterilization, disinfection, everything is perfect in your ICU, then there is no need to start any antibiotic. Just manage with your oxygen, HFNC, IV fluids and all that, and manage with without antibiotic in such cases. So infection control is the thing. If you don't have infection control, then naturally within next 24 to 48 hours, this child is going to have some infection from somebody else. So naturally you need to start some antibiotic right from day one. So it's all about, boils down to infection control in the unit, and that will decide. If you have a good infection control practice, you won't start any antibiotic. Yes, Anupama, what are the important infection control practices in the unit which can prevent a nosocomial infection and development of multi-drug resistant organisms?
The healthcare personnel, the patient, and the environment of the ICU help with transmission of these nosocomial infections and MTRO organisms. It's like a multifaceted approach, starting with education of the healthcare personnel, good hand hygiene policy, having following your standard precautions, preventing transmission-based precautions like contact precautions, droplet or airborne, and your bundles and checklists. Basically, devices like central line, ventilator associated pneumonia, and urinary tract infection in an intubated child. So it's not only the healthcare personnel, even the management. It's a structural process from the top management, from the infection control team to the individual doctor in preventing and your nursing personnel in preventing and transmission of MTRO infections.
Yes. So back to our scenario of bronchiolitis. This child started worsening after initial 24 to 48 hours of treatment. Now the child started getting moderate grade fever, worsening tachypnea, oxygen requirement, leukocytosis, elevated CRP. So now do you want to start antibiotic, and were we wrong in not starting antibiotic earlier, Dr. Chetan?
Well, in picture, yes, I'll be starting the antibiotics depending on what sort of the antibiogram I have in my unit. But I would still stick to the original decision of not starting antibiotic when the child came in, because as Parag rightly told that most of them they are viral infections, and by giving antibiotic in that, we are actually promoting development of a multi-drug resistant organisms, and there will be a selection of those organisms, and you will eventually get these. So I don't think anyone can blame for needing the child needing antibiotic after 48 hours or 3 days after the ICU stay.
Okay. So there was nothing wrong in not starting antibiotic. Child got infection, that is different thing. You may start another antibiotic for this infection, but empiric antibiotics in a viral infection will just promote development of more multi-drug resistant organisms. That we need to remember. So Dr. Parag, how do you decide whether this new fever, this new infection, new worsening is most probably because of an MDRO?
So everybody knows the timeline of 2 days or 48 hours what we think about. So child came to us with some symptoms, little bit stabilized, I would say he was like that, but not having a new worsening. By the end of a 2 day, he started having some worsening, which have escalated and required some more intervention. So that's why the child has acquired something into the ICU. So then we should start thinking about this is a secondary deterioration in the hospital, which is related to the I would say infection related to the hospital or hospital acquired infection or MDRO. So so possible reasons is, so we have to say utilizing this terminology itself blames on the hospital acquired infection. So there has to be some breach in I would say infection control. So you have to recapitulate yourself what exactly happening is, whether we have hand washing, hand hygiene, we are segregating the patient nicely, we are making it sure that the IV lines has been taken care of properly, suction, nebulization has been clean or not, the oxygen port. So all those things to blame for. But if you have a robust infection control things, so the incidence of these things goes down. And very commonly, if you ask the parents also who give nebulization at home, very rarely they clean the nebulization set. Same normal saline being utilized multiple times. So these are the few things which prevails them for the infection. Though there are features of a patient itself which promote infection, there is a possibility that child had already a lot of antibiotics outside, immunodeficiency is there, malnutrition is there, but these are actually not under our control as when the patient comes. So these are all the things we can really control and probably decrease the chances of hospital-acquired infection. Frankly speaking, there should not be a hospital-acquired infection.
Okay. So what Dr. Parag is saying is basically all hospital-acquired infections are MDROs. You cannot have an MSSA as a MDRO or as a hospital-acquired infection. Sorry. So if somebody is in the hospital who did not have an infection before, after 48 hours develops a new fever, new infection, you have to imagine that this is MDRO. It cannot be MSSA or simple innocent bacteria. So my next question is, how do you choose your antibiotics for an MDRO?
So I would go with the classical answer. You see what organisms you see in your ICU and decide about your choice of antibiotics accordingly. And definitely depending upon, so there sometimes what happens there is the child deteriorating and you have in your antibiogram 3 antibiotics which can kill that bacteria. So depending upon the sickness of a child, you yourself as a team can think about, okay, child is moderately sick, I would use piperacillin tasmat. But child goes into the shock, ARDS and all those things. You really wanted to hit hard, so you can think about utilizing the meropenem. And you have an isolate, you feel that 60% of the time was sensitive to some kind of a meropenem, but 40% of the time it was resistant to colistin. So don't feel bad in adding that initial hours, because at that point of time, there's a lot of bacterial load and endotoxemia, which should be taken care of. So antibiogram, clinical, and you have 3-4 antibiotics in your armamentarium, which we can use judiciously.
Yes, the Infectious Disease Society of North America has given a very nice suggestion. If you are suspecting MDRO, when do you suspect MDRO? When the patient has admitted and after 48 hours gets a new fever. If you are suspecting MDRO, the new antibiotic which you are going to start must cover Pseudomonas. It's a must. Second thing, you have to look at your last 6 months culture reports from your unit and see whether you have been growing more than 10% incidence of MRSA. If you have more than 10% incidence of MRSA from your past 6 months experience, then you add something which covers MRSA also. If the patient is stable, as Dr. Parag said, only new onset fever, some increased fluffy shadows on the X-ray, some increased inflammatory markers, but child is stable, then go for simple piperacillin tazobactam, which covers Pseudomonas. If you have more than 10% growth of MRSA in your unit in past 6 months, 1 year, then you can add some vancomycin or teicoplanin. Don't go for linezolid. Linezolid is only for vancomycin resistant MRSAs. If the child is hemodynamically unstable, toxic, shock, something like that, then hit first, hit hard, as Dr. Parag said, go for meropenem for Pseudomonas or some other organisms. And you may add vancomycin or teicoplanin if you are suspecting MRSA based upon your past 6 months experience of your unit. Now the question is, if a patient is on intubated, ventilated patient who was not having any infection, bacterial infection, was simple bronchiolitis or head injury, and got an infection after 48 hours, we call it ventilator associated pneumonia, we all know that. But this child was not intubated, this child was on HFNC, and this child has most probably got an MDRO after 48 hours in the hospital stay. So Dr. Chetan, how this child must have got an infection in the lungs, secondary infection in the lungs, even if the child was not on ventilator?
So usually when you have something like this, you have to go back and see where exactly, right from the time when we place the IV camera. So adhering to strict aseptic precautions, cleaning the IV camera site properly with your fluorescein as well as the clean the area, and then while putting, many a times if you don't have a dedicated kind of a tray, if in small children you will need sometimes multiple attempts, and if the IV cannula is once it is being attempted and placed somewhere else and touching something else, so these are the areas where we have to focus on this. Also, as Dr. Parag pointed out, nebulization. If same in his bottle is open morning and till the next day it is being used time and again, that also can lead to this. Most of the times, every child will have its own nebulization kit, but you have to think about all these things from where this has entered in the child. And once you have a child with bronchiolitis, there is always already inflammation going on, and then once you have bacteremia, it can simply go and it can worsen your pneumonia.
So even if the child is not intubated, what he is saying is, if you don't perform your hand hygiene properly, if you're not handling your IV cannulas properly, if you're not having your IV sets properly, if you're not taking proper infection control precautions while you're making drugs like ceftriaxone, whatever, or any other drug like Pantadac or anything, if you're not taking precautions, bacteria enter into the bloodstream, lung is already inflamed because of bronchiolitis. So when the bacteria are passing through the lungs, they start colonizing in the lungs because of inflammation, and then they produce more inflammation and the infections can happen. So even if you're not intubated, you can still get a nosocomial respiratory infection because of improper infection control in the ICU. So Dr. Kapil, how do you choose? And I think we discussed that. I'm sorry. So yeah, so basically you just cover your pseudomonas and then look for MRSA in last 6 months and decide whether to cover for MRSA or not. Dr. Nitin, so this child was started on PIPTAS, piperacillin tazobactam, and vancomycin by the treating physician. The blood cultures came positive for MSSA. Child is clinically much better after starting piperacillin tazobactam and vancomycin. What would you do now with antibiotic? Continue with the same combination, stop vancomycin and continue only piperacillin tazobactam, or stop all antibiotics, just give IV ceftriaxone?
Here, I believe that blood culture, this MSSA is a colonizer. And in rest of the centers also, blood culture capture only 10 to 50% of organisms. In this very child, this organism seems to be MDRO. I would like to stop with vancomycin. I would like to continue on IV peptides. If this child would have been hemodynamically stable and condition would have been improved tremendously, I would have decided to stop peptides also. I would have kept this child on ceftriaxone. But this very scenario, I think differently and keep this child on peptides for the duration and will stop vancomycin.
Okay, so this is basically a practice of de-escalation. Once you get a culture report, you take a decision, you review your decision of the first decision of starting antibiotic, and now you want to, that is called de-escalation. So Dr. Kapil, how it is, how much it is important for de-escalation of antibiotics?
De-escalation of antibiotics is part of the antibiotic discipline, what we call is antibiotic stewardship. But it is important to de-escalate once we have the definitive culture, once we know antibiogram for last 2 months, and then once you know the cultures are this bacteria, these are particular antibiotics. That's where you don't need to do high antibiotics to avoid the development of resistance to the bacteria. And so depending on the microbiology results, depending on the clinical response, depending on why the antibiotic was started, and the guidelines, every unit has own guidelines, we decide about the de-escalation. It's important main thing to avoid the antibiotic resistance.
So Dr. Anupama, what is antibiogram?
Antibiogram is a microbiological report. It is prepared by a microbiologist. Basically, it tells us the antimicrobial susceptibility of the hospital. It is prepared once in 6 to 12 months. Every hospital's antibiogram can vary. It gives us an idea what to start empirically when we suspect MDRO infections, and the trend of resistance of microorganisms which are growing in your unit. The trend is the same or it is worsening over a period of time. It is very important to have an antibiogram. Every unit must have one.
Right. So basically, antibiogram is where the microbiologist prepares a list of all the. I think the PPT has been changed. This is a different PPT. I had a PPT where antibiograms I had kept there. Anyway, so antibiograms basically what the microbiologist does is last 6 months all cultures they take, ET cultures, blood cultures, urine cultures, and then they give you reports. What organisms were growing in your unit, what antibiotics they are generally susceptible. So you know that in my unit, most of the Klebsiella are resistant to even meropenem. I know that most of the Acinetobacter are resistant to piperacillin tazobactam, and 70% are resistant to meropenem also. So as Dr. Anupama said, if you just get an organism first, you may get antibiotic sensitivity report even after another 24-48 hours. But you know that Klebsiella, you directly go for meropenem. You got Acinetobacter, you know that they may respond to meropenem. Patient is clinically improving. You can continue your piperacillin tazobactam. So that way, antibiogram helps you, and you need to change your antibiotics based on antibiogram. So Dr. Parag, how do you track antibiotics use and then antibiotic resistance in the unit.
So again, if you are in a good unit and you have a stewardship program, so definitely the things are automatically tracked. But if it is not there, still it is very easy to track the use of antibiotics. One is you can actually do is access to the antibiotics make, I would not say difficult, but make it little bit kind of a complicated the way antibiotic justification form. Like why you are starting this antibiotic. So when we start writing it down, the comfort level comes in changes from comfort level to the scientific explanation. So you write it down why you wanted to start vancomycin, why you wanted to start piperacillin tazobactam. And the second thing is actually when you round that patient daily, you just see about it whether we can de-escalate the thing. So one is antibiotic justification form. Second thing is de-escalation policy, or you sort of unit forms prompting that there is one of the candidate in the ICU or someone who will say, okay, this shall require this antibiotics or not. Third thing is if you have, I would say, had a microbiologist or any infectious disease consultant, that could be helpful for thinking about how we can use and deeply. Let's use this higher antibiotics. So these are the few things which you would try to see whether we can actually use the antibiotics in a proper manner and meticulously utilizing the policy as a general policy, all the consultant following the same policy. And what Anubhav Madhavan sir has said about antibiogram, stick to your antibiogram. Try not to use the funny antibiotics which you probably don't know how they work, and give a justification of what you are starting.
Something like a carrot and stick policy to change behaviors. So, Dr. Kapil, what is stewardship?
Yeah, that's it earlier. Stewardship is a discipline, antibiotic discipline, wherein there are set discipline rules or regulations when to start, what to start. With the goal of having a good patient outcome, preventing the antibiotic resistance, and at the same time, which helps in decreasing the cost of the using high-end costly antibiotics. So remember with the D, the right drug, the dose for the right duration and timely de-escalation. Very important aspect of the stewardship program. Yeah, that's the same thing again. What we discussed is the goals of antibiotic prevention of emergence of resistance.
So basically, keep a team of people who audit these things and team which supervises this and controls the practices and behaviors of the prescribing doctors about using the antibiotics. Okay, Dr. Parag, what are the challenges in establishing a protocol for the ICU? Can we establish infection control team in smaller hospitals in India?
Absolutely. What we're talking about, the antibiotic stewardship is definitely one of the very good quality indicators. What quality comes with perseverance. So basically, what the person who is trying to write down, he has to make it sure that he's writing out properly. So, you don't need a big team of people who trying to tell you not to use this, to use, de-escalate the thing. So let it be a small, just consider a small unit scenario where there is only one consultant and there is a nurse. So what you can do is, as a consultant, single consultant, you can say, okay, I am the one actually who's going to think about whether to start an antibiotics or not, and give a justification for that in a justification form. And there is a one nurse who can be trained as an infection control nurse who would try to take care of the aspects related to the infection control in the form, whether all policies related to the infection control. It could be related to the urinary catheter bundles, valve bundles, IV lines bundles, okay, cleaning of the mouth, suctioning, hand washing, all those things is followed strictly. So antibiotic stewardship is the last step. Actually, there are so many steps before that which will actually prevent you for utilizing this hard antibiotics. So you try to navigate through that, and at the same point of time, what we do, there are 3-4 hospitals sending samples to a bigger hospital. Just assume that you don't have a facility for blood culture or all culture, you're sending it to some other hospital. Speak with the person there, a microbiologist can every weekly he can visit for a few hours and go through it. He can basically very helpful need of what changes we can do it in a small ICU or small hospital to prevent the infection.
Yes, so there is no excuse that my hospital is very small and I can't have these things. As sir is saying, you can have a part-time infection control nurse if you can't have a full-time. So you can have a nurse who is a smart nurse working in the ICU or ward and ask her to work half day in the ward, half day work as an ICN. And you can request a microbiologist to visit once in a week and go through the culture reports and other things. So these are the things which you can do in a smaller hospital also and implement these things. Dr. Nitin, there is a 4-year-old child who was admitted in PSU with severe asthma, respiratory failure, needing ventilation. Child was managed with inhaled bronchodilators, ketamine infusion, magnesium sulfate. And she started improving and gradually weaned off ketamine, and you decide to extubate her. What antibiotics will you consider initially? Okay. Right.
I would not like to start any antibiotic.
In a clear asthma, yeah. What about status epilepticus, Dr. Parag? The child is coming with a status epilepticus. Would you start antibiotics?
So status epilepticus without any fever, no antibiotics. But status epilepticus with fever, with suggestive of infection, then depending upon whether I'm considering bacterial meningitis, viral meningoencephalitis,
yeah,
then I would decide about that. But afebrile status epilepticus.
And what about head injury, Dr. Nitin? No external bruising, skin is intact.
No bruising, no basal skull fracture, no antibiotic. But if there's a basal skull fracture, then you should consider adding amoxicillin to this child.
Okay. And Dr. Kapil, a 6 weeks old baby admitted because of an upper GI bleed and bleeding per rectum, was in shock, resuscitated with fluid and blood products. No fever. Is there any need for antibiotic here?
This baby came with GI bleed and bleeding here, so chronic hypovolemic shock. There is no fever in the background. I would still wait for antibiotics, not start an antibiotic. But is there anything around?
Nothing. It's only GI bleed.
So there's no antibiotic.
No need of antibiotic. And Dr. Anupama, what about dengue? Our favorite. When do you consider starting antibiotic in dengue?
Dengue hemorrhagic shock, only dengue hemorrhagic shock, stabilizing with fluids, yes, we can wait. But most of the times what we see is dengue hemorrhagic shock associated with organ dysfunction, treated in outside hospitals and coming to us. Or if you think of co-infections in dengue, like rickettsial or secondary bacterial infections, yes, antibiotics can be considered.
Okay, Dr. Anupama, there is a 4-year-old child of nephrotic syndrome on steroids. Child is looking stable but has come with cold, cough, and without any fever. Will you consider antibiotic here?
Nephrotic syndrome is an immunocompromised state. So there is a concurrent database review which said that prophylactic antibiotics might not prevent infection, but considering the immunocompromised state of child being on steroids, I would send the inflammatory markers and start on a simple antibiotic like trioxin or augmentin in such a situation.
So steroid may actually mask fever. So absence of fever is not a so antibiotic restriction does not mean not starting antibiotic for anybody. So here this child is immunocompromised. It's better to cover with something. So Dr. Kapil, 8-year-old girl with the dysuria and frequency of urine analysis showing multiple pus cells, plenty of pus cells. Child was started on amoxicillin, waiting for culture reports, and child was afebrile, active in 48 hours time. Culture reports have come and they are showing E. coli resistant to amoxicillin but sensitive to ciprofloxacin. Will you change antibiotic?
No, the child is clinically responded to his UTI. Culture report is showing something different, but clinically child has responded to amoxicillin, so I would just continue amoxicillin unless the.
So in vitro, in vivo may be different. Yes. If the child is clinically better.
Documented can be added.
No, sir. Child is clinically improving, medical legally.
Yeah, other thing we had to look into like what type of culture collected is
How was the sample collected and all that?
how the sample collected, or maybe we really have to redo the culture and see. If it is resistant, really amoxicillin resistant, okay.
Yes. So you may repeat a urine culture if you have a doubt. In the repeat culture, if the pus cells are drastically less and the bacteria are not growing now, that means amoxicillin is working. Yes. So Dr. Nitin.
High levels as compared to what you keep in the ventilation. There is a chance that it is still healing the organ.
Yeah, contamination. So Dr. Nitin, 7-year-old child with fever from last 3 days up to 101, cough, sore throat present. Child is not toxic, no respiratory distress, started on amoxiclav for 3 days, but with poor response. Fever is still present, throat pain is still there. The throat swab shows Klebsiella pneumoniae, resistant to amoxiclav, but sensitive to amic acid.
So here we are getting Klebsiella pneumoniae in a throat swab. Now we should apply our logic here that every culture with every organism is not the affecting organism. We should think clearly. We should give nebulizer or a contaminant as well. Look for the inflammatory markers. They are improving, condition is improving. With the same antibiotic, continue. If like in this child, there is continuous process. So either go on the IV route for the same with improvement in bioavailability, or go for oral ciprofloxacin. This child, I continue with IV antibiotic or will give a choice to oral ciprofloxacin.
Okay. Dr. Chetan, a 4-year-old child brought with follicular tonsillitis. Doctor wants to start amoxicillin, but parents are objecting. They're saying in US, people don't start antibiotic for sore throats. How do you tackle them?
Here we have to really our counseling skills are at play here. So you have to first tell the parents what exactly is the problem, and as you've already earlier said, that using antibiotic judiciously doesn't mean not to use it at all, and there are circumstances where you have to use it, and this is one of them, and we can explain them about the far-reaching consequences also if you don't treat the follicular tonsillitis which is at hand. Most of the time it is the streptococcus which is responsible. So you have to counsel the parents and guide them.
So we come to our last scenario now, Dr. Parag. This is a 3-year-old girl with cough, cold, fever of 5 days, progressively increasing respiratory distress from last 4 days. There is no history of travel or contact with any respiratory illness. At the time of presentation, she was irritable, tachypneic, saturating 65% at room air and 80% at NRM. And there was tachycardia, blood pressures were normal, bilateral crepitations, heart sounds were normal, no murmur, abdomen was soft. This was the X-ray. And hemoglobin was 11 grams, WBC counts 6,500, platelets 1.8 lakhs, normal lactates, mild transaminitis, or we can say SGPT is normal actually. PCT is mild elevated, 2.8. What antibiotics will you start here? Will you consider antiviral?
So if you see, this is an acute respiratory illness, gradually progressive, coming into the respiratory failure. And yes, definitely we should consider community-acquired pathogens here. But having said that, there are few clues from the investigation. There is a thrombocytopenia, both bacterial and viral infection can have both. Procalcitonin is little bit elevated, normal values around less than 0.5. So a little bit of procal elevated. So in that scenario, it is better to take care of the community-acquired pneumonia in the form of antibiotics. You can choose. It's a 3-year-old child, common organism. We know you can choose amoxicillin or ceftriaxone. Now about antivirals, yes, similar things can be there because if you see, we know that we just spoke 70% have viral infection, but on these patients, almost 30% can have a supersetted bacterial infection. So there are only few RSS we can treat off. So you should definitely think about them starting. This kind of a child who have actually rapidly deteriorated hyperinflated chest, okay, having a complete lung involvement, you might be dealing with a more diffuse process than the localized process. So I would say amoxicillin or ceftriaxone, and yes, I would definitely consider antiviral.
Like oseltamivir.
Oseltamivir and not remdesivir.
So this child was actually started by the clinician on piperacillin, tazobactam, and azithromycin with oseltamivir. Now, one thing is about azithromycin. As per American Thoracic Society guidelines, any child who's attending school or daycare center comes with respiratory illness should be started on a macrolide. So if this is a 3-year-old child attending a nursery, coming with an LRTI, has to be covered with azithromycin. In neonates, if the child is in the NICU for a very long time, again, LRTS can be because of urea plasma, urea laticum, again, which requires azithromycin. Otherwise, that is different. But up to 2-3 years is fine. But if the child is attending a daycare center or a school or a preschool, then you need to cover atypical organisms as far as Australian Thoracic Society recommendation is concerned. Anyway, this child was on piperacillin, tazobactam, azithromycin, oseltamivir, intubated, started on mechanical ventilation, required FiO2 100%, high PEEP, and rates. Ventilatory settings were improving after some time, and the blood culture and ET cultures were sterile. H1N1 came positive. Now, what will you do?
So we got the cause first thing, but still blood cultures, ET cultures were sterile and chat is clinically improving. So if my antibiotic would have been amoxicillin and ceftriaxone, I would continue that. I would definitely give 5 to 7 days depending upon the clinical symptoms. But if it is piperacillin, tazobactam, and azithromycin, definitely I would de-escalate to the routine antibiotics as soon as possible.
So basically, ceftriaxone We can stop piperacillin tazobactam and go for ceftriaxone and continue oseltamivir. Azithromycin you may give for 3 days and then stop. Any questions? Any doubts? Azithromycin. Azithromycin. Yeah, it's about school age. It's about school age. A child attending school usually in India is 5 years. But if they are attending at 3 years, then you need to consider that. Because now PP, PP1 and pre-primary are.
Most of them are in daycare or in PP1. So we have
Yes. Yes. No, we have seen mycoplasma coming positive, mycoplasma IgM coming positive. So many IgM positive. Actually, if you see on the Frank Shan, no, the back side of Frank Shan, they mentioned that.
Why I am telling you, azithromycin is rescued in the OP line. Most of the pediatricians write asthmaticus. It is capsule that uses azithromycin. So why I am telling you, winter will have entire extreme drug resistant typhoid. Azithromycin only.
Yes. Right now we are already facing that.
Yeah. In that case, if you start using for viral, you end up in problem. Without that one, but only for typical pneumonia and gas. And cefixime, don't use cefixime for respiratory.
Yes, I've seen a lot of people using cefixime for tonsillitis.
No cefixime about the.
Yes, madam.
In the list of all the no for antibiotic use, one is surgical conditions. Those children go to theaters. Like, do you consider giving antibiotic or no for, or do you give this for any GI surgeries?
Yes, surgeries are divided into 3 categories: clean, contaminated, and contaminated. For clean surgeries, normally antibiotics are not required. For clean contaminated, that means where the abdomen is being opened, but peritoneum is not. Peritoneum also may or may not be open, but gut is not open. So that is contaminated, clean contaminated. And contaminated means gut. You are handling the gut. You are actually, so you need to start antibiotic for clean contaminated and contaminated. And for that, the recommendation is at least 1 to 2 hours before the surgery, 1 dose of antibiotic has to be given.
And just about the antifungals also, could you cover something about it?
I deliberately did not cover that. Antifungal linezolid I didn't want to discuss, and I didn't want to discuss tigecycline and colistin. Sorry?
In an OP also, a lot of people like just seeing a person and they will start using it. Or children are being sent on after getting admitted for 2 days because this is one drug which is
over the counter
for vancomycin-resistant enterococcus, but its main name it is available in oral form.
Oral form, over the counter.
It is available in oral form. It is very easy to prescribe.
Yes.
So I think we should.
So linezolid is only reserved for vancomycin-resistant enterococci and vancomycin-resistant MRSA.
Or sometimes atypical mycobacteria.
Or very deep-seated lung infections or bone infections, something like that, soft tissue infections. And antifungals are basically for immunocompromised patients. And a dengue with multi-organ dysfunction with immune dysregulation is also an immunocompromised patient. Sometimes you may have to start, or somebody in the ICU for a very long time on multiple antibiotics, already, for more than 10-15 days and marasmic, and you are suspecting that there is strong suspicion of fungal infections, you may start. Otherwise, better to avoid antifungals and peric. Yes, that's what it's a. Yes. So now, what the recommendation by the Infectious Society Disease of this thing IDSA is that multi-drug resistant organism nosocomial after 48 hours of stay in the hospital, whatever antibiotic you start must cover Pseudomonas. That's a practical this thing. So it usually covers other organisms also. That's just a thing. Anti-Pseudomonas antibiotic has to be started. Then you look at your last 6 months experience of MRSA. If you are growing lot of MRSAs, cover MRSA also. Because sir, lot of times, when we take exams also of our fellows, they whenever there is VAP, they will always say vancomycin. VAP means vancomycin. It's not like that. If your MRSA incidence is very less in the unit, you don't have to start vancomycin for every VAP. Pseudomonas. Yes. So yeah. So if a patient is already on meropenem and vancomycin and comes to you, and that child was admitted in that hospital for just 1 or 2 days, and you think that this child is very stable, you may at least come down from meropenem to piperacillin tazobactam, stop vancomycin, send all the cultures and wait and see if the patient is stable. And if you know that unit also, the referral hospitals also, most of the times every hospital will have fixed their referral hospital. So they will generally know what organisms grow from there when they come. So that also roughly you can think about it. And you need to politely tell them to have good infection control practices in their unit. Because I've seen people taking tap water and keeping in the humidifying chambers. In the ventilator, in the humidification chamber, they take tap water and put there and they ventilate. And when I asked that pediatrician, he's saying that this is not going in blood, no, he's saying. So it's very innocent.
I think the bottom line is antibiograms, big policies, better communication, making it a point that we come down when we know there is no growth. I'd also like to add here that in trauma, when we see polytrauma, like Sarah said, it is classified into clean, contaminated. We have to decide whether to give antibiotic clean trauma, like a blade cut or things like that, and if it's a road traffic accident, then coverage of relevant organisms should be considered. The trauma is always it should be covered. I think that is
yes. Yes. Yes.
One more doubt. So in this post-COVID era, I've seen many people coming to me, the age group from 9 months to 2 to 3 years, and most of them they are having the presentation with the NSA piracy of unknown origin, basic baseline parameters and investigations are coming normal. Only the CRP levels are mildly elevated, and mostly they have already received one course of either antibiotics, the fever is first thing. So most of my patients, I got a test blood which are showing IgG and IgM antibodies from a very reliable center, and most of the patients they were showing IgM positive and IgG also positive with persistent fever, even after one baseline course of antibiotics. So for these cases, I can't believe me, sir. I had a case of hematoma with the child who was not out of trauma. Just out of my curiosity, I got a D-dimer test for the test, which was elevated. And for the same child, I got a
COVID positive. Antibody is positive. We are getting lots of patients like this.
For such cases, do we need to start any antibiotics?
No need.
For the fever, we need to just wait down and see what happens, or any baseline antibiotic like azithromycin. Some of the patients who are about 2 years, they responded to doxycycline for 5 days. The fever came down drastically.
Maybe the fever settled down on its own. Because in yes.
Everyone is seeing once levels are there after 1 month.
See, if the patient is coming with fever in OPD, if the patient has mild fever and you have a definite focus, then there is no problem. Throat infection, treat it. If there is no focus, fever is going on, just give symptomatic treatment, ask them to follow up after 2-3 days. If the fever is persisting in this COVID era, beyond 2-3 days, you send some labs, which you are doing already, CRP, ESR, usually we say. For MISC, we send both CRP and ESR because we are finding both are elevated. Now CRP, ESR, both are elevated, but your patient is absolutely stable and there is no focus anywhere, only fever is going on. So now this is most likely MIS. You send antibodies in 60-70% patients, antibodies may be positive. In 20-30% patients, we have seen that antibodies also may be negative, but still it is MIS. So having positive antibodies is not diagnostic of MIS. Now, once you have MISC, there are 3 possibilities which can happen. One is the child may remain persistently febrile for some days. There may be some elevation of liver enzymes also, mild jaundice also, all those things may be there. But over a period of 4-5 days, everything will settle down if you just wait and watch. The second possibility is they may go for a myocarditis, cardiogenic shock, very bad multi-organ dysfunction, all those things. And the third is Kawasaki-like illness, where coronaries will be dilated and you will have high CRP and ESR. So if the first category, where the patient, you're just waiting, watching, after 3, 4, 5 days of waiting, watching, also suppose fever is persistent, but patient is not deteriorating, neither going in shock nor going in Kawasaki. You got a 2D echo also done, you sent your troponin I also, everything is fine, but fever is going on. You can give a touch of methylprednisolone, 1 mg per kg per dose BD. For 2 to 3 days, it will settle down. Fever usually settles not like magic. With one dose itself, it will settle down. So that's one thing. Second category is a shock. When there is shock, you have to admit, manage shock, or refer to a place where they can manage. And they will usually, troponin I will always be elevated in these patients. So it will be usually myocarditis. So they will give IV IgG for myocarditis and methylprednisolone. Now there is a controversy whether you should give 1 mg per kg per dose BD, or if you pulse methylprednisolone 30 mg per kg or 10 to 20 mg per kg. Lots of different guidelines are there. Normally we give 1 mg per kg if the shock is manageable. If it is a very fulminant shock, we give a pulse methylprednisolone. Now the third category is Kawasaki, where the management is very standardized. You have to give IV IgG 2 gram per kg, and wherever you give IV IgG, there is no 0.5 gram or 1 gram per kg IV IgG. Dose of IV IgG means 2 gram per kg. Patient was poor, I wanted to give 1 gram per kg. You will be unnecessarily stuck in partially treated Kawasaki or partially treated MIS type 2, and you will be in unnecessary problems. So 2 gram per kg. If the child is fluid overloaded on day 1, you may give 0.5 gram per kg on day 1 and then get rid of some fluid overload with Lasix or dialysis. And then 1 gram per kg next day can be given. 2 gram per kg IV IgG with steroids 1 mg per kg for Kawasaki. Look at the platelets. If the platelets are less than 4 lakhs, we are seeing lots of Kawasaki-like illnesses with low platelets. So no aspirin. If the platelets are between 4 to 6 lakhs, 4 to 5 lakhs, then low dose aspirin. If platelets are more than 5-6 lakhs, then proper high dose aspirin, which we give for Kawasaki. IV IgG. The latest American Heart Association says that 3 gram per kg IV IgG is the dose for Kawasaki, classical Kawasaki. You know, 2 to 3 days. No, it depends. Generally, it is 2 to 3 days. In first 1 to 2 days, you will finish your 2 to 3 gram per kg per first 3 days. But if the child is fluid overloaded, you may give it over 5 days also. So, but 2 gram per kg is generally we agree. If the fever is still continuing after 2 gram per kg, we can give 1 gram per kg. And if the fever is still continuing, then we think about infliximab. Immunomodulator. It's a controversial subject now. Azithromycin is an immunomodulator. It is well known. It has been used by rheumatologists for many years as an immunomodulator. So, Doxy is also immunomodulator. Right, sir. Thank you very much, all the panelists. Sir, ask me.
Now I am playing the role of treasurer to say what are thanks. My sincere thanks to the faculty of Rainbow, Dr. Farhan Sheikh, Dr. Anupama, Dr. Parag, Dr. Kapil, Dr. Chetan, Dr. Nitin, because your presentations are so good, very useful to practicing pediatricians like me. I really enjoyed and learned a lot. I hope all the other participants have learned a lot. I request Rainbow people to conduct similar academic events involving intensivists and other aspects as well. So thank you one and all. Thank you.